to fight against preeclampsia. We are so excited that you are here this morning. Let's give ourselves some clap, very hot one. As we lap, we are working against preeclampsia because blood is moving to our brains and we are thinking, we are acting. Whatever we are doing is to prevent, manage preeclampsia so that women and community as large will enjoy good health. So the theme for the symposium, this year's symposium, is Beyond Half Point SDG 2030.
Global health perspectives on hypertensive disorders of pregnancy, disparities, challenges, and solutions. We are all here to find those disparities. We are here to discuss the challenges. And of course, we cannot leave here without discussing the possible solutions and the roles we each have to play to manage and control preeclampsia. Of course, the dream is to eliminate it, but for now, we'll do with finding solutions that will help protect the mother and the baby. You are all welcome to this morning's symposium. Thank you.
Thank you very much, my co-MC. So we'll begin the session with a prayer, and we humbly invite Dr. Betty Anani Fanning to give us the opening prayer. I hope you've not forgotten the womb.
Good morning, everyone. Can we bow our heads for a word of prayer? Our Father in heaven, we thank you so much for today. We thank you for giving us life. We pray that just as you were with us yesterday, you be with us today too for a successful program. In Jesus' name we pray with thanksgiving. Amen.
Thank you, Dr. Fanny. So we now call on Prof. Fonjo to give us the welcome address. Please, let's welcome her with a clap.
Wonderful MCs. Good morning to us all. It's a pleasure to be here with you this morning. And I want to, on behalf of the Planning Committee, welcome you all to this wonderful gathering, the 6th Preeclampsia Conference. So APEC has, over the years, organized this symposium. And I would say we have largely traveled across the nation to talk about preeclampsia. And all the years we have discussed various themes, all geared at ensuring mothers have healthier pregnancies. And this year is no different, and my MCs have highlighted the reasons, the 3 main reasons why we are here. And I would like to reiterate that the main objectives of our symposium this year is to discuss the challenges faced at the various levels of care, the primary, the secondary, and the tertiary levels in managing this condition. We are also here to investigate how the disparities in healthcare access and socioeconomic status affect maternal health outcomes in relation to hypertensive disorders of preeclampsia. We are equally here to explore the interplay between hypertensive disorders of pregnancy and other maternal issues as we strive to arrive at our SDG 2030. And so these are the main reasons and the focus areas that we are gathered here for this morning. But beyond this, I also encourage us to interact, to network, to fully participate, to engage in today's discussion so that we have fruitful deliberations and fruitful discussions. Already, like I mentioned, all geared at ensuring we have healthier pregnancies, more women giving birth alive, having our babies alive. And so as we all gather here, I encourage us to interact, to network, and to fully engage in the discussions. And so on this note, on behalf of all the Planning Committee, I welcome you to the 6th Preeclampsia Symposium here in Kumasi. Thank you all very much.
Thank you very much, Prof. Today she is acting as the chairperson for the program. That was a wonderful welcome address. At this point, we will watch a very short video on global perspectives from Global Patient Organization.
Hi everyone, my name is Lainey Foy, the Director of Communications and Engagement for the Preeclampsia. Hi everyone, my name is Lainey Foy, the Director of Communications and Engagement for the Preeclampsia Foundation. We're a US-based nonprofit organization that helps raise awareness of hypertensive disorders of pregnancy. We are so thankful for all the great work that's happening in Ghana and for being asked to just be a part of this global conversation on World Preeclampsia Day. A big thanks to the organizers and to the team at APEC Ghana for all that you all do. It can be very challenging to face preeclampsia, no matter where in the world you are. That's one of the reasons that we have World Preeclampsia Day. It's my privilege to get to convene a group of organizations that work all around the globe to help mitigate the complications that occur because of preeclampsia. These organizations are there to support families in all kinds of settings and all kinds of situations. We're thankful to be a part of that, and we're thankful for all that each and every one of you are doing on behalf of women and their families in Ghana. Thank you so much for allowing me this opportunity. It's my privilege to get to convene a group of organizations that work all around the globe to help mitigate the complications that occur because of preeclampsia. These organizations are there to support families in all kinds of settings and all kinds of situations. We're thankful to be a part of that, and we're thankful for all that each and every one of you are doing on behalf of women and their families in Ghana. Thank you so much for allowing me this opportunity, and keep raising awareness.
Hi, I'm Candace. I'm a British obstetrics and gynecology trainee currently working in Sierra Leone in West Africa. I have a really strong interest in preeclampsia, and as such I'm here to represent APEC. As an organisation, we have worked the world over, most recently in sub-Saharan Africa. We've worked in Zambia and Zimbabwe and Malawi and Kenya. In South America, we worked in Brazil, and the other side of the world, we've worked in the Philippines. It is our role as an organisation to try to understand the lived experiences of women who have had preeclampsia. And through this work, it is our overwhelming belief that preeclampsia is a condition that is just so poorly understood. In other places where there may be a word for it, it is often seen through a lens, a religious lens or a spiritual lens. For example, in Sierra Leone, in my context, the word for not necessarily preeclampsia, but eclampsia is devil sickness, and that translates to the devil's illness. And in like the most rural areas, for example, when a woman has an eclamptic seizure, it isn't like the doctor they call, it is often the traditional healer. This just highlights the point or the work that we want to do and that we are doing, which is to try and speak to these communities, to try and understand why a disease that is so prevalent is so little understood or acknowledged.
Most of the women hear about preeclampsia for the first time when they are affected themselves. Even if they had heard about it earlier, they didn't anyway.
Hi, my name is Ashley Muteti from Zuri Nzilani Foundation here in Kenya. And one of the most popular sentiments that we hear from women is women starting their antenatal clinics late and at a very advanced stage in their pregnancy, is they come to the antenatal clinics when it's already too late for the doctors to do anything meaningful to save their life or the life of their baby. And that's where we advocate for preconception care. And also, once a woman gets pregnant, they should start their antenatal clinics immediately.
Here in the US, many women hear the word preeclampsia for the first time when they're diagnosed. I suspect that this is true in Ghana too. All of you as clinicians and patient advocates can be a part of changing that, making sure that every woman knows that word and understands that hypertensive disorders of pregnancy can be very severe.
There is no doubt that women experience all manner of emotional problems after preeclampsia, and one of our jobs as a patient advocacy organisation is to make sure that we are there for those women, we are able to help, and we are able to give good advice. There is support available in the UK. It could be better, but we have to do what we can do. Many women will turn to family or friends for advice and support. They will ask other people, but what's most important is they do get the help that they need.
Women who have gone through preeclampsia experience a lot of mental health challenges, and this is because the society has sidelined this particular type of women. As we know, women who have gone through preeclampsia can lose their baby, so they can experience infant loss, they can experience pregnancy loss, they can also experience preterm births, and this can be subsequent pregnancies. And due to these particular issues that affect the woman because of preeclampsia, the women are at a very vulnerable point in their lives where most of them have lost their marriages. In Africa and here in Kenya, children are considered as a sign of wealth, as a sign of
I think one of the really important things that women need is to be informed, well informed, even prior to pregnancy, about preeclampsia, what it is, what it can mean for their pregnancy. And they also want to be informed about what will happen next to be done.
As a global community, we have a responsibility to ensure that patient voices are heard and that we create better experiences for families who face a preeclampsia diagnosis. It's quite interesting that no matter where you are on the globe, the experience of preeclampsia is quite similar. You are often quickly diagnosed. You may have confusion or concerns or worry when that diagnosis happens. And a lot of the time, your baby has to be delivered quite suddenly. No matter what that scenario is, we help women to know what preeclampsia is and to help them to get to care quickly should it occur. It's my hope that one day we will have better ways to predict, prevent, and prevail over preeclampsia. Your partnership is critical to that process. Thank you.
Thank you very much for the video. We would like to have some comments, some thoughts that are going through your mind as you have listened to this video and watched the video. What are your comments? What are your thoughts? Do you have questions? Yes, please.
One of the speakers missing in Ghana. We are not doing it at all. So what are we going to do to, start that concept so that even before a woman conceives, the care that is needed to be given, at least we'll be able to modify some of the risk factors for preeclampsia. And I believe if we're able to do that, it will make a great difference. And some of the complications that are associated with preeclampsia, I think, will be reduced. So what are we going to do so that we can start preconception care? Thank you.
Thank you very much. Preconception care, very important. Dr. Shroff wants to. Okay.
So my
play it along the line so that you can get some important information before you leave here today. All right.
So I'm Dr. Yao Owusu. I'm Dr. Yao Owusu Jante, maternal fetal medicine, Confanoche. All right. So preconception care, we were not practicing at all. But currently, if you come to Confanoche, though we don't have a separate clinic for preconception care, the same clinic that does the antenatal care, there are dedicated personnel for doing some sort of preconception care. What I think we can all do as clinicians to improve it, antenatal care started same. We were having coverage of up to like 20-30% with education done for preconception care. All clinicians, it can be family physicians, internal physicians, seeing women as in reproductive age women, should make contraception an integral part of the care they give to these women. Because that is one of the surest way we can get women to attend preconception care. If you are on contraception and you feel then you want to get pregnant, let's say somebody has sickle cell disease, right? She's being seen by a hematologist. Hematologists should discuss contraception. Once the woman wants to get pregnant, refer to ONG for some sort of assessment. If we assess and we think she is good to embark on pregnancy, then she stops the contraception. Until we all do this, we will always be picking our women when they are pregnant, rather than getting them at a stage where we can influence a lot. Thank you.
Thank you very much, Doc. Thank you for sharing your experiences. The video is ready so that we can all be informed. Yes, please.
All right, thank you.
Hey, sister Kosia, you say na fata will say, hey, when I sing na ta when you ma and I want sadie, I kesia, mit musa upnu show, na you saying so dear, a fata will net, see me won't so, sa no say,
Anio, you saying the wire kesia, a fence of half fefe.
Who sent an wire fe? Shasani and Nimuna air shrine. Why, why come, why fe, papa? You say fatal.
Hey, mo dear mo. Bebu ohonu mayana mitie me ya. Eto de bia e ba na ekọ. Na bisu wo ho a mani su timi chi me kakra na me yefu su timi me kakra. But yesi sa na nyin sentie. Enche bia ni nyina su betwa na me ba na ba.
Akosia. Bra kwa me yire no. We twa hwe yesi ade ni kwa yaresabia. Sense mo amukeka wa ha ni nyina no e na na eye no nyin sen ni mo. Yen kwa yaresabia sesia yen kwa hwe yediem.
Mr. Boateng, medawase se one antia kosia aba yaresabia. Severe preeclampsia eye nyinsen mo yare bia eye apemfo efri bosomenum eko. Yare yi ema moja broswo na ebetumi amama ame no abofra no ana omomie no nyina ahwere wo monkwa. Yare yi ema apemfo no enim ne nan ene ne nsa ana ni hunam nyina honhon ema etipaye eya woni yem obehu ade mienu ana neni so beye ne hweren se wanye ho hwe a esro betumi aka no se onim opemfo bia niama we amaboso ye na tonefo se onko ayaresabia enko hu doctor.
Dam nkatoi wana wazibeye the Preeclampsia Initiative na Ministry of Health so was one sashase.
Okay, so thank you. Please, are you okay? You're fine. So it's straightforward. These are the symptoms and the signs of preeclampsia. So we'll just take 2 more comments and then we close.
Okay, so
this session.
For me, I believe that almost every clinician that works with pregnant women have a knowledge about preconception. And when clients have faced and confront them, they're able to provide the care. But the truth is that the clients don't even know that we provide such services in the first place. So when they need advice on things like this, they tend to talk to their friends or people that they believe have some knowledge about it. And the time they will come to us, it will be too late. So I believe advocacy is the first choice. They have to know. As young, even those in secondary school, from that point, they should know that if I want to get pregnant, then I have to see a midwife or an obs and gynae specialist for them to guide me through when we do that, they even know their risk factors and know that, okay, my mother in quote or in my family, somebody has some of these conditions which I'll be at risk at. So in that case, then I'll have to do A, B, C, D to help me not to get there. So I believe we should inform them, then they'll come at the right time.
Thank you very much. It's true. It's all about advocacy, and we are happy that the young ladies and young men are here to join us today so that they will know about it and they will begin to have conversations around it. It's always important to start the conversation. So as we are here, we've started the conversations with these young ladies. We believe that when you go, you start having these conversations with your colleagues, that you just don't get up and get pregnant. If you really want, if you want to be pregnant, you should plan for it. Most of the time, we don't plan our pregnancies, especially when you get married. The first time, some of us will come back from honeymoon pregnant. We haven't discussed any pregnancy with anybody. We haven't even discussed it with our partners. We just want to be pregnant. And so you get pregnant, and then all the other things that are possible can happen. But we can always prevent some of them, if not all of them. So thank you for this conversation starters, and we are believing that, as we have said, we are going to be change makers. We are proposing solutions. We are going to make something out of this symposium. This is the 6th one. We cannot come back every year talking about the same things and the numbers keep going up in terms of mortality. So let's do something starting from us. Okay, so I wanted to really end the comments, but 2 hands continuously poking my eyes.
Yeah, thank you. My name is Dennis.
Dennis.
Yeah, from South Sudan.
Right.
So, talking about preeclampsia, I think one thing that stands out in this African context is wrong misconception of what preeclampsia is. Like, as we saw from the video, how we perceive preeclampsia to be and how we understand it, it plays a very crucial role and create awareness in our communities so that the people get to know that this really exists. So it will play a very important role in this. If we don't have accurate data on, let's say, how many cases have we recorded this year, then how best can we approach this to reduce the rate? It's not just data, it should be quality data. So data that is of high quality is very important in determining the right measures to take. So then how can we get the accurate data or quality data? So we have to leverage technology. For example, in Kenya, there is Mama's Hub. So it's an app, a mobile app. They have trained community volunteers to collect data on pregnant women. This data that is being collected, it's reported directly to the nearest medical facilities. And when there are critical issues, report situation. So I believe if we can leverage technology,
Thank you very much. I believe that with the support of the Ghana Health Service and Minister of Health, we shall travel far with the advocacy. My issue has to do with the sustainability. Many times when we have issues like this, the moment we get to the peak, we know a lot of people are now aware. We go back. Is there any policy to sustain it going forward?
Because I'm not Ghana Health Service and I'm not Ministry of Health. But I believe that we all have a role to play when it comes to sustainability. And in fact, it's the reason why I believe APEC Ghana is having this symposium annually, for us to be able to get some information going every now and then. But when we come, we are the agents of the sustainability. We are those supposed to continue to take the message out there for everyone to know about it or to play, especially the Division for Health Promotion. But we also have a role to play. And as we know, being puffy in pregnancy does not mean you are going to have twins or you are going to have a baby boy. It can be a sign of a big danger. So that presentation this morning, and it is on co-creation of a toolkit to assist risk communication and clinical decision making in severe preeclampsia. Spot impact study design. This is going to be done by Dr. Hannah Amwako Brown. Please let us welcome Dr. Hannah Amwako Brown. Thank you. Okay, good morning. So as mentioned, my name is Hannah Brown Amwako. Everybody kind of decides how to call me. They always end with the Brown, so I'm very, very used to it. But it's the Brown before the Amwako. Whilst we wait for the tech issues to be sorted out, yeah, okay, I think we are good to go. So I'm a member of the Sports Consortium. And today I would like to share with you what we have done as a study in terms of designing a tool that we hope will facilitate risk communication and clinical decision making in severe preeclampsia. Next slide, please. So I have a very brief presentation outline. We'll go through some introduction, discuss objectives, methodology, and then I will talk to you about some discussion and conclusions from what we have done. For those who are researchers here, you may immediately realize I don't have a results section, and that it's because the purpose of this particular, please go back, I haven't moved. When I'm ready to move, I'll let you know. IT, can you go back? When I'm ready to move, I'll tell you to go on to the next slide, please. Okay. So there's no results section in this presentation because this presentation is actually about how we have designed a means to develop a tool. We want to share our ideas with you, our experience with you, and hopefully during the Q&A session, we get feedback from you and also learn from you. So that is the essence of this particular presentation. So I'm warning you, there will be no results in this presentation. Next slide, please. So we've heard a lot about preeclampsia, and I can't emphasize that it is a big problem. And if you look on your right, the graph that you see, I don't have a pointer here, but basically what that picture you see there is showing you the distribution of preeclampsia, of maternal mortality in the world. So globally, this is what you see. And the darker the color, the more maternal deaths that occur in that area. And I think if you are able to spot Ghana where we are not too far from the very, very deep, is it red or pink color, right? So we do have very high maternal mortality rates. We are now at about 263 per 100,000 live births, which is a lot, a very far off cry from what we expected to reach by 2030 through the SDGs. And we have also known that about 15% of these are actually caused by hypertensive disorders of pregnancy. Next slide, please. Wait for the slide. And it really did show that indeed those who are really having the worst outcomes are those who have hypertensive disorders of pregnancy much earlier. And I think a lot of us, the clinicians, know why. Now, we also do know that disrespectful maternity care practices are common. They are common globally, but even more common in low middle income countries. And we also know that shared decision making, risk communication, which are known to in as a team, what are we going to do if we say we are going to create a tool like this to improve quality of care? We thought of these 3 dimensions. I think in our previous video, one of the speakers mentioned something about prediction. Is it possible for us to be able to determine that woman A, who is age 25, her weight is 70, who has had preeclampsia before, her mother has had preeclampsia before, she's standing in front of you, can you predict her risk of getting adverse outcome? What is it? Or at least, can you tell her absolute risk score? For instance, well, women who are like you, 7 out of 10 of them will end up with a cesarean section. Is there a way we can? Thank you. Okay. Yes, it's working. Thank you very much. Sorry about that. So are you controlling from there or I'm controlling from here? Sorry. Can I control from here? Now. Okay, thank you. I'm not able to move. No, there. I can't move the slides on from here. It's the wrong one. Let's switch back to what we were doing. Okay. Yes, I can use the pointer, that's fine. Okay. So can we, I'll tell you when to move on to the next slide, okay? So do move to the next slide. That's where we were. Okay. Sorry, sometimes IT problems come up, but we'll manage. Right, so if there was a way to now communicate to this woman that, for instance, someone with your kind of profile, 7 out of 10 of them will require a cesarean section, that's important information to know. So you, the healthcare worker, you're able to do that assessment. But we want to also go beyond me knowing that you are likely to need a CS. I need to be able to communicate whatever risk that I have estimated per your profile and gather. I need to be able to communicate it. We realized that risk communication support was lacking. So in our toolkits, we aimed to have a risk communication support and then a shared decision-making support. Is there a way to engage the pregnant woman, her spouse, relevant family members, to agree on how she should be managed? I mean, even if she's going home because she became stable, what are the tips? So some kind of engagement. So that is what we thought of as a team to be the main 3 components of the SPOT 2. However, we are also mindful of the fact that contexts differ. We understand that. Please go back. Please go back. Now you're at the end. Please go back. You are at the end of the presentation. You need to go back. So again, we have 3 main components of the SPOT 2. However, we also understand that there are different contexts and situations when it comes to clinical care. We are not asking clinicians, midwives, doctors to say, okay, there's a certain tool available. You need to predict risk or be able to gather information on risk, communicate the risk, engage in decision making under all circumstances. If you have a woman who is cesarean, fitting in front of you, certainly, I don't think you have time to go and do any shared decision making. So that's why in our thinking in tool developments, the idea was to create a tool with distinct components so that depending on the context and indeed the preference of the client and the healthcare worker, we could apply either the risk scoring components in that situation or go on to even communicate the risk and then engage in shared decision making. If it's not possible, then yes, you have predicted the risk. This woman needs a CS now. Baby needs to come out now. She's fit and I can't even communicate. You move on and do what you can. Or you communicate and you realize that she says, yeah, you know best, just do everything for me. She's not really ready to engage in shared decision making. There is that flexibility with this tool, and that is what the SPOT tool or toolkits will hopefully emerge to be. Next slide. Right. So as part of the process of what we call co-creation. Co-creation, if you just look it up on Google or something, it's like a term in business where it's said that the customer has a say or gives input in designing a product right from the start to the end. So we borrow from there and say that we also want people whom this matters to or are involved in this context of preeclampsia to be involved. We, the researchers, are not interested in sitting behind our desk and then doing something and then putting it together and bringing it to healthcare workers to use. We want to co-create it. And as part of our efforts, we outlined a very elaborate process consisting of 6 phases in our co-creation process. Because we are interested in sharing our methodology with you, I will talk just a little bit about what we did over here. So we have a phase 1. I'm not too sure how clearly you can read, but then we engage in quite a bit of literature review to understand what was available when it comes to co-creation, what has worked, what has not worked before. And then as a team, we developed our co-creation approach and then had to identify what are the questions that are important to address, even as we want to co-create this tool to improve the quality of care for women with hypertensive disorders of pregnancy, particularly preeclampsia. And then, of course, we wrote it up, went through ethics to get our approvals and all that. Then we have a phase 2, where we called exploration, where we did more literature review to understand shared decision-making, risk communication. What is effective communication? As an example, we have a publication on that one. And then engaged in some data collection to give us an idea of how we are going to co-create this tool. We have a synthesis phase where we pull together all the information because we gather quite a bit to try and actually get to a stage where we actually construct the tool. We are actually at the phase 4 at the moment. We are putting together the tool. I think we will be done hopefully by the end of this month or early next month, and we will have a SPOT tool out there. And there is a plan to implement the tool because we've created something, but we need to see if it works. So we will implement it and then hopefully evaluate it and then be able to scale up, hopefully. So in our minds as a consortium and as a study group, this is how we wanted to approach developing a tool that will help with predicting risk, with communicating risk, and with engagement in shared decision making where possible in the care for women with preeclampsia. Next slide, please. So then we had these very nice objectives. And the rest of the presentation actually focuses on what we did for the exploration phase. That's the phase 2. This was our main objective: to co-create a toolkit to support clinical decision making, communication of risk, and shared decision making, but based on certain core principles. We wanted to incorporate respectful maternity care, which is a priority of the WHO and we agree with, justice and equity principles. And specifically, we were interested in assessing the barriers and facilitators to meaningful co-creation, to assess the understanding, preferences, and suitable forms of risk communication and shared decision making, and to assess personal, interpersonal, and systemic barriers and facilitators to shared decision making. And I'm sure that if there are clinical people here, they'll be very happy with this last bullets because usually you get a lot of questions about how do we do this in our setting. So we sought to address that. And I always like this picture I have over here because I find it so amazing that these kids can draw something so beautiful, and some people seem to be standing upside, they are looking at the paper upside down and they still manage. But then it tells you the diversity of the skills of these children, even as they paint. So in our minds, we also want to co-create a tool using various stakeholders, because we understand that they have different backgrounds, different expertise. We want to put it all together and make a tool that is fit for purpose. Next slide, please. So I mentioned principles, and I wanted to quickly share with you just a few of the frameworks that as a team we decided to work with. So we have what we call the produce model. So in developing a co-creation methodology, one of the things that's important to do is to make clear what your objective is. And I think I just mentioned our objective to you. Then the D is to agree on the design. Like I mentioned, we chose to co-create. Others could have decided that they would read literature and put things together and then have a tool. We decided to go the way of co-creation. Then the issue of end users. When you make the tool, who is going to use it? You need to define it in your thought process. In our situation, is this tool going to be used by just the clinical staff? Are midwives using it? Are doctors using it? Are the patients using it? Are survivors using it? Is it that the ordinary person, male participant, is interested in using this? This becomes very important in the process. And then who will be your co-creators? These co-creators are the various stakeholders that you would engage, and you need to spell it all out as part of the process. And then, of course, I've mentioned evaluation and scalability. Again, one of the frameworks we decided to work with had to do with justice. So this was developed by a colleague of ours, Bridget Pratt. It's a Justice for Global Health framework. And in this, it says that for research to incorporate justice in what it's doing, you need to be inclusive in your research population. You need to look at, for instance, vulnerable populations. And we believe that women with hypertensive disorders of pregnancy can be, quote-unquote, be considered as vulnerable. Why? Most women have nice, safe pregnancies, nice outcomes, but these women, they may have to stay in hospital for weeks. So our inclusion of them in our data becomes very important. Again, we consider people who have disabilities. Blind people, albinism, for instance. We try to bring their ideas on board in the co-creation process, just so that we know that there's justice in what we are doing. Selection of a research topic, I think, is very clear based on all the conversations we've had yesterday and today, that answering this question about how you communicate and engage in shared decision making shows that you are indeed putting some justice into the work you do. When it comes to developing research capacity, what we have done as a study is that we have, through our collaboration, allowed north-south engagement. So we have had foreign interns, I think there are many of them here that you can see, to come in and learn. And then we have also locally tried to develop the research skills of our local students and some freshly graduated doctors as a means and proposition about developing research capacity. Regarding providing auxiliary care, if we did interview people or spoke to women and realized they needed support in certain areas, for instance, connection to mental health support, we were available to do that. And as for knowledge translation, I think we are sharing the knowledge right now, isn't it, of what we have done. Next slide, please. So based on that, having had all that in our minds, then we decided to go out and do this. We worked in 3 of our referral facilities. We looked at women who have preeclampsia. We looked at survivors of preeclampsia, spoke to them. We spoke to healthcare workers, different cadres of healthcare workers, facility managers, policy makers, and like I said, people who live with disabilities, just to get their ideas on board to be able to co-create this tool. And we use snowballing, convenience, and purposive sampling to just get to know the right people who will be able to help us in the process. We use qualitative data collection methods such as focus group discussions, interviews in person, on phone, through Zoom. We did observations. Please go back one step as well. And then, of course, in our analysis, we have done thematic analysis facilitated by DDoS, which is a software for qualitative analysis. Next slide. So like I mentioned, we don't have results to show you because the focus of this is to share our experience in engaging in the process of co-creation. And we believe that we have a strength in how the approach we have chosen because we are using a transdisciplinary approach and it deepens and broadens the insight gain as we collect the relevant data. And the wide range of qualitative, data collection techniques that we also employ also allows for in-depth insights into the current practices and experiences of hypertensive disorders of pregnancy patients and healthcare practitioners. And we hope that at the end of this, we will be able to co-create a really great tool that is fit for purpose. Next slide. I think we managed to publish our protocol fairly recent, I think last month. So if you are interested, you can find it at the Global Health Action website. Again, this is the DOI. Oh yeah, it was accepted. We published in May, actually, so this month. And I will end here, and I would also like to acknowledge many collaborators, which is on the next slide, please. Yes, so we are a huge consortium with many collaborators, and it's through the effort of people in all these institutions that we've been able to get to our goal as a study team. This is for sports, and for sports, we have not worked in Confanoche, unfortunately. This is not for APEC. Okay, thank you very much. Okay. I think we have room for a few questions. Thank you very much, Dr. Brown. Please, let's clap for her once again. And her team. They've done a good job. And we are expecting to see you bring it to us in the Eastern region for us to pilot it so that we can co-create. All right. Yes. All right. So please, if you have questions, we have opportunity to take 3 questions for Dr. Brown. Questions or comments. We know they've done a good job, so let's ask her questions. Esther. Questions for Dr. Brown. The students, do you understand what is going on? There's a lot of English and science. Don't worry. We'll get there small. All right.
Thank you, Doctor. I think one of the pointers was the disrespectful maternal care practices. Since we have not seen the results, we don't know whether there have been some proposed measures, especially the low and middle income countries. It's really in the facilities. So what do we do as a country to remove or curb this canker? Thank you.
Thank you very much. Any more? Let's take all 3. Yes. The last person.
Hi, good morning. I was wondering, in your methodology, you say you include 3 referral hospitals. Is that, in Ghana, do you mean tertiary hospitals, or what kind of setting is that?
Then the last.
Okay. Let me start from the last question. So, in Ghana, our tertiary hospitals are really our referral hospitals, and they have the capacity to deal with cases of preeclampsia. I stand to be corrected, but in the Ghana Health Service system, you need to be at a regional hospital at the minimum to be cared for. Once you are picked up with preeclampsia, we will not manage you for now in our secondary level facilities like the health centers. You need to go up. So that is how it works. Regarding disrespectful maternity care, I can tell you that what we have done as sport, we did actually pick up up in our data collection. And you will remember that our tool component, there's a risk communication part. And part of what our tool is doing is to give prompts to healthcare workers when they are engaging their clients in their management. So yes, there are prompts because the client said to us, they speak to us like this. We don't like it. Can they speak to us like that? In a cool, friendly, nice manner. Take your time. Talk to us seriously. So in the tool, there are prompts here and there to guide the conversation that the healthcare provider will be. In the tool, there are prompts here and there to guide the conversation that the healthcare provider will be having with their clients. So hopefully both clients and provider will have a good experience in the process. So at least that's how we have had to deal with it. And it's really based on feedback or from the data that we have collected, the responses that we had led us to make the tool as it is, or as I have described.
I think I have one question here too. Thank you for your presentation. I really like the fact that you use co-creation as an approach to developing the tool because it promotes then local ownership and ensures the tool hopefully becomes more sustainable. Are there any other concerns you have regarding ensuring that the intervention is sustainable, stays, does not, like many other tools and interventions, disappear over time?
Yeah, good question. And it's something that we have been talking about. And if you remember the produce model, there's evaluation, there's scalability. So we have a nice tool. We believe we have a nice tool, but we also need to show that it works. And we are hoping that once we are able to demonstrate that it works, we have senior members of the Ghana Health Service here, and they are also part of our stakeholders. They are part of our co-creators. So we are hoping to keep that engagement going so that in that case we are able to scale up, and then there is that local ownership. So for instance, one of the things we are trying to do is to develop an app. Where will the app be hosted beyond sports? Those are conversations that we are already having and thinking about, and hopefully that will help us to be able to keep it going once we know it works, and we are hopeful that it will work. Thank you.
All right, so it should be approached with respect to respectful maternal care, right? So if every hospital makes it a policy by ensuring that midwives, doctors stick to this policy that has been in existence since 2018, I think that component will be taken care of.
Thank you, but if I can just react briefly to this, I think it's a very important thing. But I think something about WHO guidelines that we have all increasingly realized is that they tell us what to do, but we have our own local context. So we have to really make it fit our context. And that's one of the things we are hoping that we would have captured with, the sports too. So it's good to know, I agree, but we also need to make it work for us. And we have to find a way to make it work. Okay. Dr. Strauss.
Thank you. A little comment on the referrals of preeclamptic patients and where they are taken care of. I think currently, because of the availability of specialists, i.e. obs and gynae specialists at the peripheries, some of us are doing quite some job at the peripheries. I work in a primary care hospital, like a primary facility, and we take care of a lot of preeclampsia patients. So I just wanted to make that clarification. Thank you.
Thank you. Is that my classmates? I can't see well.
Thank you very much. Please don't leave. I have a concern or another contribution. I teach at the Public Health Nurses School. And as you were discussing the co-creation, I was thinking that your team could discuss with HTI, Health Training Institutions, because we have a program, we are into the preventive health service. So as part of the training, we take the student to the field every week, and then they're large all over the country. We have students who are reading public health nursing, and you can use or work with them, partner with them, so that as they go into the community, because you are talking about early detection, they'll be able to give health education, they'll be able to identify and refer. So as we talk, let's also think of partnering or looking at the pre-service, let's let's work with them so that together we can identify, look at the promotive and the preventive part, especially during the co-creation.
Thank you very much, and we are working with them.
Okay, thank you.
So we'll talk more later.
Thank you very much.
Thank you very much, Dr. Brown. Thank you. So,
a special one this morning.
thank you so much. Would like to acknowledge the presence of Prof. Samuel Opon. He was not with us yesterday. Prof, please, you are welcome. And we thank you for gracing us with your presence. Thank you so much. All right, so we'll now have our second presentation on Global Pregnancy Collaboration Lecture. A digital health information system for maternal and child health services in low resource settings, proof of concept study. It will be taken by Prof. Ali Kashan. Please, Prof.
Good morning, everyone. Can you hear me? Yeah. Dennis, thank you so much, because you did my work already with your question about data. So thanks for the invitation. I'm delighted to speak up a bit. I will try. Is it working now? Thank you for the invitation, and I'm delighted to be here today. So I will be talking about a project that started 7-8 years ago. So I'll tell it as a story more than research methods and so on. So this is a project in collaboration with KCRI in Kilimanjaro Clinical Research Institute in Tanzania, and originally funded by CoLab, the Global Pregnancy Collaboration. They gave us a small amount of money to develop the prototype that I'm going to talk about, and then we got a larger grant from Irish Research Council to do the work that we've done over the last 3 years. Next slide, please. Okay, so we started working on this project in 2016. We went on a research of a medical birth registry that was established, developed by University of Bergen in Norway. And after 10 years of funding, they ran out of funding. And it was a very basic birth registry where they entered the data on paper records, and then they entered them on a computer, basically. So if there was any problem, they would have lost the data. It was just a basic desktop. So that was an area we identified as something we wanted to work on. But we wanted to do more, because digital health and the data we need to improve maternal outcomes, neonatal outcomes, if you want to reduce maternal mortality. As we know, in recent years, maternal mortality reduction, maternal mortality rate reduction has stalled. So all the work that has been done and reduction in maternal mortality in so many countries has stalled. So something else needs to be done. So we identified digital health as an area of collaboration with KCRI. And initially we helped them move their birth registry from a computer, just a desktop, into Caster, which is a database based in Holland, but it's a license based. So your data is saved in a third country or a second country in Holland. And at the same time, we have to pay a license fee every year. And we're trying to get out of that. Next slide, please. So from the first meeting, or we had a week of meetings, we identified few areas that we wanted to work on within the digital health. And just to remind you that all the work I'm going to describe, I'm not going to talk about that, but it's within or in line with the WHO Global Health, Digital Health Strategy, in line with the agreement between the African Union and the European Union on digital health innovation. So all the work we are doing within that framework, I'm not going to mention in my presentation. So it's very basic what we wanted to achieve. We wanted to develop a system that allows users to enter data online or offline. Internet is a problem. Relying on the internet to enter the data is not going to work. So we wanted to get around that. We wanted users to have control over their data. We wanted an open source system. We don't want any company to benefit from this work. We wanted the users to have full control. Next slide. In addition, we wanted the system to work at all levels. So a couple of years ago or less, a scoping review was done on digital health in sub-Saharan Africa. And the title is eHealth or eChaos, which tells you a lot, I think. And they identified more than 900, just in 10 years, more than 900 tools or digital health interventions, if you like, that were used in sub-Saharan Africa. They looked at 738 of them. And they decided what's happening is eChaos, not eHealth. Because everyone is working in silos. Every hospital work on their own. And you have smaller projects, everyone wants to do their own app, and so on. So what we wanted to do is to get out of the in silos work and to do something that works at different levels. So you can link, like in Tanzania, there are 4 or 5 different levels of healthcare facilities. How can you link all of them together? So data harmonization within country, across countries, etc. And we decided that DHIS2, which many of you would be familiar with, I think, it's a platform developed and maintained by University of Oslo. It's used in like more than 80 countries at the moment. In Tanzania, it is used for aggregate data. Next slide, please. Now, we planned everything. We wrote our grant, and then with our collaborators, and we went to meet when we started the project with the local health authorities, with the regional medical officer and his team. And we proposed our own dictionaries, and they said, no, no, no. We have our own health information system. We have our own questionnaires that are used across the country in maternity units, and you have to use those. So we implemented, instead of trying to develop new questionnaires, we implemented their own questionnaires into the system. And they said they wanted a notification system. So we're talking about a digital health intervention. I'm not using that terminology, but that's what we are referring to here. Where somebody, I think Dennis or someone else mentioned, so if a woman has preeclampsia, the minute you enter into the system that this woman has preeclampsia, few people would be notified. Now, who is to be notified and what they should do, etc., that becomes another issue. But the system, without the person entering the data, is doing anything. The minute you press the button, emails or text messages would be sent to few people in the region or the district. so to make sure that this woman is followed up. They wanted to remind women about appointments. Now, this is something I wasn't convinced about personally. I don't think women miss appointments because they can't remember them. There's some like broader social issues that we have to address. But we developed the messaging service, so the day before an antenatal care visit or appointment, the woman receive a message. And they wanted patient referral system summary for clinicians to use, and we developed as well. Next slide, please. So we did a few surveys. The first survey was before we implemented the system. So we asked, this is the survey we used, the questionnaire. Then next slide, please. So we approached 100 participants from Tanzania and Malawi. We just wanted an external group, 15 people from Malawi. And we asked them to complete the questionnaire. So they had to install the app and enter the information about 15 questionnaires as if they are entering pregnancy data and complete the survey. And the score we got was almost 70, mean 70, which is saying the system is good, it can be improved, but we are on the right track. Now, always there are issues with these surveys. There's never a perfect survey, and you ask the participants to focus on the technological side. You still receive comments about we need this variable and that variable, and so on. But we had a good start. Next slide, please. Then we did a landscape review. And just say one thing about landscape review. We thought that in the Kilimanjaro region, 30% of women deliver at home. The first finding from our landscape review was that that's zero. Women in Tanzania are obliged to deliver at a healthcare facility legally. So on records, there were like less than 1% of women who delivered at home. And that's kind of tells you about the information we have and the reality on the ground. So identified the area and how many healthcare facilities, so we can start preparing our work. Next slide, please. So we started in October 2022 at the 3 dispensaries, so that's the primary care level, and we selected the 3 dispensaries that have the largest volume of birth, and then in November, then 2 months later in January 2023, we started large health centers, like 2,000 births a year, each of them, and then we moved into the regional hospital earlier this year. We had to provide 2 to 6 tablets per facility, depending on the structure of the facility rather than the volume of work that they have. Next slide, please. So this is the type of data that we collected. I'm not going to look at it, just to show you how the data is produced, because this is important for research, for epidemiology research, for RCTs. We could, and next slide, please. And the next one. So the challenges we had from this phase was internet. So even we provided a SIM card for each facility, still connectivity was a problem, and we don't know whether it's the connectivity, they ran out of credit, they are not standing in the right spot for connectivity, so there were a few things to get around. Double data entry. They still had to enter the data as normal, and the same people were entering data twice, although we were paying for the extra work. And the hardest one is that in hospitals, they have their own electronic system. So they enter the data on paper, they enter the data on electronic records, and actually in one of the hospitals, in Moshi District Hospital, they had 2 electronic systems and a paper record system. So we didn't want to get in there because we thought we might be causing harm rather than improving it. The next slide, please. Okay, quickly, so we did 2 more surveys after implementation. And the first was for users. We asked them to comment on our system and the paper record system so we can have some sort of comparison. The score this time was slightly lower, original one, but that's not surprising. It's a complex system. So some of the questions, if you look at the survey, actually it is a cumbersome system. We can't have a simple system to cover all antenatal care and delivery and child care. But overall message was that they preferred electronic systems. This seems to be like well known now, that electronic systems are far more preferred over paper records. Now I will show. Okay, so we asked a few questions about mental demand and physical effort and being under pressure, frustration, performance, and between the Mutuha paper records and Ultra. Ultra is the name of the system. And it's very clear that they are sick of the paper records. And if we know that around 1/3 of the healthcare workforce is spent on data entry on paper records that are hardly used, that's understandable. And when we asked which system would you prefer to use on a regular basis, it's like 30 out of 31 participants said they prefer an electronic system. But we didn't take it as they like our own system, so we did focus groups and the qualitative work to say, do they mean any electronic system or this system in particular? So we wanted to get deeper into that. Next slide, please. And then we compared the system and paper records with users who were not exposed to the system at all from other clinics to see if the mental demand, physical effort, and so on, these 5 questions. And again, users or nurses, midwives who just simply use paper records were targeted, it seems, from the current system. Next slide, please. So we can say that we have shown that we implemented the system. We were able to implement the system to replace paper records. And the system is acceptable. It's liked by the users and it satisfies their needs. And more importantly, that the data is produced can be used for epidemiological research. We are doing a study already, and the first finding, as you would imagine, that half women start their antenatal care late, 49% or so. The first visit is late. But still, the main challenge is the political decision making. Our initial estimates suggest that the current system is not cheaper than an electronic system. The money spent on paper records, on the books they use, and the amount of time they spend on these books, the paper books, is very expensive, but that needs more work. Next slide, please. Okay. These are some of the people that were involved in the project. And the second from the left is my co-PI. Some of you might recognize Chris Redman and Jim Roberts. And final slide, please. And these are the names of the co-authors. Thank you.
So we'll take 3 questions from you, and then we'll move on. Please.
Ali, thank you very much for your presentation. It was a wonderful one. My question is simple. Your challenge listed, I saw the internet connectivity being the main challenge, and then in your conclusion you mentioned the political decision. It is clear that the electronic is cheaper compared to the people. Do you have any recommendations as to how, because it cut across the whole Africa, and then the low resource settings. If you review literature, everybody that publishes actually mentioned this being the problem when it comes to data collection and this setup and all that. So do you have any recommendation moving forward that can be used to correct this, because it is something that we need to apply or we need to employ to make the data collection improvement a thing of the past. Thank you very much.
Thanks. Now, about the internet connectivity, the system doesn't need internet all the time. So all you need is internet connectivity a couple of times a day to synchronize the data. But when it comes to referral systems, like if you want to refer a woman from a dispensary to a hospital, you must have internet at that moment. And if you want to use the system for clinical care, for the healthcare professional to see the data, you are requesting data from the server, so you need internet connectivity. So part of the system would work with very minimal internet connectivity. Other functionalities would need internet. But we were working on an EU grant application with East African countries, and somebody from Norway is working on improving the internet connectivity. They have additional technology that would allow the connection to improve. Now, in terms of political decision making, I don't know. All I know is that this is being discussed at all levels. In Tanzania, at least, every week they have a meeting, and every week in the Ministry of Health, this is something on the agenda. And there are strategies, there are plans. To choose a system seems to be a big step. And I don't know why, but what we've seen in Kilimanjaro is that actually, first, it's wrong to compare a system that would function with a system that is not functioning. You're just collecting data for no good reason. The comparison is not great. But even if you compare the current system, the paper record system is expensive. And if you think about how digital health improves outcomes, add it to the health economic equation, I don't think it needs a lot of convincing. It just needs somebody to consider.
Yes, hi. So thank you very much for your presentation. So my question has to do with your systems usability skill. If I recall, before you were somewhere in the 70s, and then it dipped to 63.7. And I'm wondering whether you understand and know why this was the case. And of course, if you do, what measures are being put in place? Because the easier the system is to use, even the better, the greater the chance of, its scalability and longevity in the use. Thank you.
Now, there are a few issues there. The first survey, it's cumbersome. You get less points, but the system is cumbersome. It's designed to be there's a level of complexity. So the survey itself is not perfect, I would say. So it's more about an app and not a full healthcare system, if that makes sense. So although the score was lower, but if you compare a 15-question survey with, I don't know, maybe 200 question survey, I would believe the second survey more than the first one to start with. But more importantly, I think it reflects the complexity in the system that you cannot get away from. If you want a very simple system, it's not going to address the needs of those facilities, if that makes sense. Okay. Thank you so much.
Thank you very much. Thank you, Prof. We move on to the next presentation. A presentation on the continuum of prevention of maternal and perinatal mortality and morbidity due to hypertensive disorders of pregnancy in LMIC settings, a review. So let's humbly invite Dr. Emmanuel Schroff. Schroffenyo. Pasha. Trauma. Good.
Thank you very much for the introduction. I crave your indulgence over the next 10 to 15 minutes to look at this very important topic. Thank you very much for the introduction. I crave your indulgence over the next 10 to 15 minutes to look at this very important topic. So, as you can see, this is going to be the outline of the presentations. Let's move on to the next line, the introductory slides. So, we have said it over and over that preeclampsia, that first of all, that maternal mortality is a huge problem, especially in our part of the world. It's a huge problem in our part of the world. And it is also important to underscore the fact that increasingly the contribution of preeclampsia is taking over in some parts of the world, taking over from hemorrhage. Hemorrhage has been the leading cause, and this has been said, especially in our part of the world. Preeclampsia is becoming commoner and contributing significantly to maternal mortality. Now, next slide. A population-based epidemiological study of the trends of hypertensive disorders have shown that hypertensive disorders contribute significantly, but whilst other causes are reducing over the years, hypertensive disorders have not reduced significantly over the years. And this is a concern. Let me have the next slide. So, for example, between 1990 and 2017, whilst the rates of maternal mortality fell significantly, the largest reductions were observed in hemorrhage, 70% reduction in maternal mortality. Of course, this is as a result of various interventions. Sepsis and other maternal infections had reduced about 45%. Abortion and miscarriages has reduced about 33%. These days, I hardly see maternal mortality from abortion. It's almost vanishing, but relatively little progress was observed in death due to hypertensive disorders of pregnancy. Only 18%. So whilst others were doing 70% reduction, 45% reduction, hypertensive disorders did only 18%. And so when care is not taken, what will happen? Is that sooner or later, since hemorrhage graph is going down, hypertensive graph is going rather horizontally, sooner or later, hypertension will take over hemorrhage as a leading cause. So the situation in Ghana is not any different from what is happening in many developing countries. But important to know that although hemorrhage continues to be a leading cause of mortality, the contribution again from maternal mortality from hypertensive disease is also on the increase. For example, the Imang survey data that was available, the latest that was available, has shown that whilst hemorrhage contributed 17% to maternal mortality, hypertensive disorders contributed 16%. They are almost doing neck to neck already at the national level. Level. And so in many secondary and tertiary institutions already, hypertensive diseases have overtaken hemorrhage as a leading cause. when you go to Kolebo Teaching Hospital, and I'm sure Comfort Teaching Hospital, and then when you come to the Greater Accra Regional Hospital, already hypertensive disorders have overtaken hemorrhage as a leading cause. Next slide. So it means that there must be an intervention. There is something that we have to do in order to stem the tide of death from preeclampsia. Epidemiological disease prevention model is one model that has come to mind. We have to have a plan. We have to have a system to follow to be able to prevent mortalities from preeclampsia. So based on this epidemiological disease prevention model, is conceptualized as primary, secondary, and tertiary prevention. So if we want to prevent death, we can look at it at the primary level, secondary level, and tertiary levels. Primary prevention involves measures to prevent occurrence of the disease. So if we look at preeclampsia, what measures are there for us to prevent occurrence of preeclampsia? That's primary prevention. Normally, primary prevention involves measures such as lifestyle changes, micronutrient supplementation, and vaccination if the disease is amenable to vaccination. These are primary preventive measures. Then we talk about secondary prevention measures, which involve screening to detect the disease early. So we put in place measures to diagnose those who are developing the disease early. Put in place management measures so that the disease does not come up with complications. Next slide. Then tertiary prevention involves appropriate management of the condition when it occurs. So eventually, when a woman is diagnosed with preeclampsia, what management systems do we have in place to manage the woman appropriately so that she can survive? So these are the three measures. The three preventive measures. However, recently, two additional measures have been added. The first one is primordial measure, primordial prevention. Primordial prevention involves risk factor reduction targeted towards the entire population through focus on underlying social, environmental, and physical conditions that promote the development of the disease. So that is primordial. And the quaternary prevention refers to actions taken to protect individuals, be it the patients or the persons, from medical interventions that are likely to cause more harm than good. So these are the other two additional measures that have been put in place. I will take you through these measures as far as preeclampsia is concerned. Next slide. So for primordial prevention, what can we do to take advantage of primordial prevention of preeclampsia? We should promote population-level interventions to reduce risk. Whilst primordial prevention is looking at risk factor reduction, primary prevention is looking at managing the risk factor. So here, what are the risk factors? When we look at obesity, lack of exercises, chronic hypertension, what population level measures can we put in place to reduce these risk factors? We should promote exercises. We should have green environment. We should have our road network must have places for people to exercise, to walk, or even ride bicycles, but we don't have that in our part of the world. Recent systematic reviews report an increased risk of preeclampsia with increasing severity of environmental pollution. Environmental pollution. This is a huge problem, especially in our part of the world. There is the need to implement measures to reduce ambient air pollution, particularly particulate matter with aerodynamic diameters of less than 2.5 micrometers. These are the ones that are easily absorbed into the systemic circulation and therefore becomes available and cause all the inflammatory changes that predispose the woman to develop preeclampsia. So this one can be said that it's more in the realm of the politician or people at the higher realm of affairs. They have to put in place measures to make sure that these are achieved. But at the individual level, there is something that can be done. Promote the use of cleaner fuels in domestic settings, especially in lower middle income. Indeed, in Ghana, for example, a lot of measures have been put in place by the political people to promote LPG, the usage, domestic usage of LPG, to reduce the use of biomass and wood, because these have been found to predispose women to more pollution, more local environment pollution. So something is being done. However, recent discussions on the media have shown that there has been some reduction in the patronage. So the emerging evidence about the relationship between lead is missing there, lead poisoning and preeclampsia. We should take this seriously and carry out further research. The presentation was done yesterday to show that lead poisoning is also contributing to the increase in preeclampsia as we saw. Next slide, please. So what are the interventions for primary prevention? We should institute preconception care to identify and manage risk factors such as obesity, diabetes, chronic hypertension before the woman embarks on pregnancy. This was actually discussed earlier on. The question that was asked by somebody was, how are we going to make this a policy? Already, Ghana Health Service has introduced a policy on wellness clinic. And again, somebody from Comfonoche said that yes, all the antenatal clinics are mandated to also do preconception care. But Ghana Health Service, within the Ghana Health Service institution, has made it mandatory for all these institutions to run wellness clinics. And I think that we can encourage young women, newly wedded, or any woman who might be thinking of having a baby to go to these wellness clinics and be checked before they put in place a plan. And these clinics are mandatory within Ghana Health Service institution. And so as the teaching hospitals are also putting in place systems, I believe that if the necessary advocacy and education goes on, people will know that the opportunity exists for me to be checked before I embark on pregnancy. There is now adequate evidence to show that adequate intake of calcium during pregnancy reduces the risk of preeclampsia. Now we have enough evidence. The dose of calcium that was originally recommended by WHO was 1.5 to 2 grams. But 500 milligram tablet, very big. Pregnant women are not fond of taking that tablet. The question is, how are we going to promote this? That is the challenge. In meta-analysis, studies have been done to find out, can we do with smaller doses? In a meta-analysis, including network meta-analysis, a medium dose of 1 to 1.49, that's almost 1.5, has been recommended for low-risk individuals. This works to 1 gram tablet works to 2 tablets of the 500 milligram one. So it means that the pregnant woman has to take it one morning and one evening to get the 1 gram. Or one morning, one afternoon, one evening to get the 1.49 gram, for example. So that is the issue. We should promote early initiation. And for the high-risk people, we have to use a minimum of 3 tablets. That is 1,500 milligrams. Now, it is also important to promote early initiation of antenatal care. Formerly, people come to antenatal care at any point of time that they like. Ghana Health Service have put in place systems to make sure that pregnant women book early. Indeed, once you know that you are pregnant, the woman is to book at the clinic so that you have time to do the risk stratification and put in place all the measures and make sure he's taking all the micronutrients, including calcium, before the pregnancy advances. But the question is, how well are we doing this? At the last time data was collected, it's only about 43% of the women in Ghana, from DIMS data, only about 43% of the women in Ghana book at the first trimester. The rest wait till the pregnancy is advanced. Something has to be done. We have to do advocacy. We have to do community education, and so on and so forth, so that people can know when they can book. We have to also apply risk prediction. For risk prediction, we have several approaches. We can have clinical risk, that's mean arterial pressure, biophysical risk, and biochemical risk prediction. Most of the others are really difficult to do. The technology is not well established in our part of the world. But what we can do is clinical risk prediction and the use of mean arterial pressure. And so if all our pregnant women book at the first trimester, and we apply these risk factors for them and check mean arterial pressure, we should be able to know those who are at risk to develop preeclampsia. The performance of this clinical risk may not be as good as the biochemical test and then the uterine artery doublets. They may not be as good, but at least it's identifying some population of those women at risk. So the earlier we take advantage of this, the better, because the assessment, the stratification is costless. All that you need is an algorithm, and I know that Prof would come and talk about the algorithm. You need is an algorithm that will tell you that this woman is high risk, this woman is low risk. And then the last one for secondary prevention is risk stratification and the use of low-dose aspirin. I'm not going to go much into this because a next speaker will be talking about this. But it is important that people are risk stratified. Yeah. Next slide. So secondary prevention. We need to also put in place systems to enhance early detection of the disease. No longer should we be there till the woman who has severe preeclampsia or even fit or have HELP syndrome before she's detected to have preeclampsia. Then we are not helping the system. So what systems can we put in place to enhance early detection? First of all, to implement early antenatal bookings. So we spoke about that. The situation is improving. Currently, the country is doing 43%, but that is not good enough. Early antenatal booking, effective antenatal programs. There are times women still go to the antenatal clinic. Like yesterday, there was a story. The woman who went to the antenatal clinic, she had epigastric pain, and she was given magnesium trisilicate to take. So it means that the visit she had was not effective. She had preeclampsia. By the time she got home, she fitted, and she was brought dead to the hospital. She did not survive. So meanwhile, she attended the antenatal clinic. So it means that there is something ineffective about the antenatal clinic that she attended. She had a sign. How was the BP checked that the BP was not detected? These are questions that were running through my mind. Whatever it is, the visit she had was not an effective visit. So we need to see, we have to have programs to promote access to antenatal services based on the access model. Based on the access model, bearing in mind the 4 pillars of access. The first one is financial access. How well can the women access? If we have clinics that are not running the National Health Insurance Program, then the clinic will be there, but the patients are unable to access it. So that's financial. The next one is geographic access. We know many parts of the country, there are no nearby clinics. Some of them you have to cross a river before you get to the nearby clinic. What are we going to do? What systems is the country going to put in place so that all these women can have a quick access? Then we talk about availability of the service. Sometimes the clinic is there, but the service is not available. The staffs are not friendly. And so even though they are there, the people in the community cannot use the service because they see something wrong with the service. And then the last one is acceptability. Once you have the service and you have quality, if it is quality, people will accept the service and utilize it. So these are some of the pillars of access. We should promote the role of community health nurses to mobilize and follow up pregnant women at the community level. One problem with preeclampsia is that Sometimes it can take 1 week to develop. So the woman comes to clinic today, her blood pressure is completely normal, everything is normal. If we don't have a follow-up program, and the woman goes home, your next visit is 3 weeks. So you tell the woman your next visit is 3 weeks. Between that time, anything can happen. So we have to have community programs where community health nurses can be doing visits in communities. Or like now we have CHIP compounds, so that there should be, all these services must be available. If suddenly the woman feels that there's something wrong, there should be a place that the woman can go and have a blood pressure checked. Do we have those systems in place? So those are some of the things that we need to be putting in place. Institutional and community pregnancy schools. It's obvious that people need education. Our pregnant women themselves need education. But it is not enough to educate the pregnant women alone. Their husbands and the other members of the community are critical for this education. Because when you educate the woman alone, it comes to the house, and the husband says that, look, or the mother says that, look, what you are saying is not true. This is how you will do it. Then the woman has no power. And so the most important thing now is to scale up pregnancy schools into the communities where we can invite other members of the community to listen to the talks. That is critical. And then finally, implement self-BP monitoring for high-risk pregnant women. And so when you come, we stratify you and we say that you're high risk. Even if we give you your next visit is 2 weeks, that is still dangerous. We don't know when this blood pressure will start checking. There have been studies that have shown that people who have come to clinic, their blood pressures were normal. By the time they were ready to come for the next visit, their severe hypertension has occurred with all complications. And so this idea of implementing self-blood pressure monitoring for high-risk pregnant women is important. And it can be done in Ghana too. Recently, there was a study in Kolebu Teaching Hospital where specialists were interviewed, and some of them think that, yes, this is something that is implementable. So this is something that we have to take up and see. The question is, when you advise the couple that your wife is at risk, she needs to buy a BP machine and take home so that she can be checking. Then the next thing is to set up a system where the values can be transmitted to the doctor, because she might not be able to interpret them herself. Next slide. I will soon be coming to a close. So for tertiary prevention, we are focusing on the quality of care, improve referral networks, first of all. And so yesterday, there was a talk of air ambulance concept. We also do have the WhatsApp referral concept, where you can communicate. In the past, you will be there, you'll be surprised by a woman who is fitting. You have not prepared to receive such cases. And now we have a WhatsApp communication system. Even if the staff, the receiving hospitals are not by their phones, you put the message by WhatsApp and you describe all what is happening. They can receive it, and then they can start some preparations before the patient comes. And then availability of essential medicines, for example, magnesium sulfate. In the past, we're told that nurses and midwives working alone in the health centers cannot administer magnesium sulfate. And so what happens is that when the woman comes fitting, they have to refer to the next level. Whilst the fitting continues, the woman does not have the advantage of initial receiving of magnesium sulfate whilst she's carrying on with the journey. This must change. Currently, National Health Insurance does not pay for magnesium sulfate administered at the health center. And so these are things that at the national level, Ghana Health Service level, and then at the ministry level, we have to be addressing to make sure that magnesium sulfate and other antihypertensive drugs are available at the health centers, where the initial treatment can be initiated before the woman is transferred. Timely and appropriate interventions, including applications of the right mode of delivery. So when you look at Habitat 1 study, this is a study that looks at preeclampsia at the early stages. Non-severe preeclampsia at term, immediate delivery is promoted. Then Habitat 2 study shows for mild diseases at late term, 34 weeks to 37 weeks, routine immediate delivery does not always seem justified. And so this one promotes that you can allow the woman to advance a little. But remember, we are talking about non-severe disease. You can allow the woman to advance a little to allow the baby to have better chance of survival when the delivery is eventually done. We need to also have an adoption of validated risk prediction model, like the PS model, which we are trying to validate in our sports study in Ghana to assist clinical decision making and promote timely delivery of women with severe diseases remote from term. So what indicators will show on the woman, and that is what the PS studies is about. What indicators on the woman will tell you that, well, this woman is only 30 weeks. She has severe preeclampsia, but let me take her a little bit more, or let me deliver her at this point. That is what this is about. We have to establish protocols for the care. We have to implement obstetric triage and meals chart. There is currently a nationwide scale-up going on, and patient and family engagement along the management journey. It is also critical. Final slide. Final slide. So for quaternary prevention, as I explained earlier on, we should avoid overdiagnosis and overtreatment. Overdiagnosis can lead to overtreatment. So let's say if the woman hasn't got severe disease and you classify the woman as severe disease, it means that you are going to expose the woman to certain treatment modalities that may rather cause more harm than good. So one of the ways that is easily available is to promote the use of proton creatinine ratio, the use of this device to prevent overdiagnosis or even underdiagnosis, because we know that when the woman is dehydrated, the urine protein level become artificially high. And if the woman is well hydrated, then the urine protein level becomes deceptively lower. But when you use the proton creatinine ratio, then you are getting the right thing. And so this is where we should be going to. Through advocacy, we should advocate to our authorities to make these devices available for use. Thank you very much. I'll leave it here. So through this measure, through the use of epidemiological disease prevention model, we should be in a place of preventing preeclampsia and also pinning. Thank you.
Thank you very much, Dr. Strofenyo. So we'll quickly take the two presentations, then we'll take Obeng, and she'll be presenting on economic cost analysis of hypertensive disorders of pregnancy. Dr. Obeng, yes. Please, let's welcome Ms. Obeng.
Thank you. Thank you so much. Okay, so as she rightly said, my name is Akosia Poko-Obeng. Not the Akosia in the video, actually, but then. So I'm making this presentation on behalf of the Sports Consortium, and the topic for this presentation is an economic cost analysis of hypertensive disorders of pregnancy. So our outline for the presentation will be an introduction, why the study is important. We'll present the conceptual framework that we used, some research methods, the results, discussions and some conclusions we made, some limitations we encountered, and a few recommendations we want to make from the study, and some acknowledgement. Okay, so generally, we know that the first and third goals of the Sustainable Development Goals aims to reduce poverty and to also ensure good health for all. They are actually specific targets of eradicating extreme poverty and also to reduce maternal and infant mortality by 2030. In 2019, we realized there was a study that showed that 99% of worldwide deaths that were related to hypertensive disorders of pregnancy were recorded in low middle income countries. And HDP, I think from what Dr. Schroff mentioned, he gave us a rundown of how among the other institutional causes of maternal and infant mortality, it's somehow taking lead, and we can see from that. But aside from the health aspect, in the cases of severe morbidity and mortality, there are economic consequences of the individual, right? And such as unplanned interruption, their labor redistributions. Because when the woman is hospitalized, severe morbidity, household members have to now take up new roles they were not ready for. And this affects their jobs. This affects productivity, both at home and at the workplace. This goes a long way to affect their standard of living. And so we could say that with all these situations around, HDP is threatening the progress we can make towards achieving the targets of the SDG goals. Please, on the next slide. Why is the study important? We believe that quantifying the economic burden of HDP may help sensitize stakeholders to give it the needed attention. Seeing how much pregnant women in the household are going through in terms of economic wise would give to give them the attention and know that this is pulling a lot from the household, not just in terms of their health, but their standard of living. We also believe it will guide policymakers to set priorities, identify possible strategies, and to strategically allocate resources towards them. So this study aimed to estimate the economic cost of hypertensive disorders of pregnancy at the household level. Next slide, please. So this was the conceptual framework we worked with for the study. So in the case of morbidity or mortality, we're looking at the direct cost, we're looking at the indirect cost, and some intangible effects that were associated with hypertensive disorders of pregnancy. And under the direct cost, we make some specifics to the medical direct cost and the non-medical cost. Okay. And around the indirect cost, we focused on the lost productivity, the value of time. In our context, we don't see hourly rate for wages, but then if a woman is spending an hour out of work, she's losing income, right? And complications such as HDP take them out of work than usual, than what the normal pregnancy would have done to them. And so this is the conceptual framework we are using at the household level. Please, the next slide. So our research methods. This was a quantitative cross-sectional study that was nested in the sports study. And so women with a history of HDP in the Greater Accra Regional Hospital between 2021 and 2023 were invited to participate in the study. And so this included women who were already enrolled on the sports study and some new women that were recruited from the Greater Accra Regional Hospital. And the exercise started in July 2003 and we ended in September 2023. Okay, please, the next slide. Okay, with the data collection, so a structured survey was answered through 3 different sources: face-to-face or phone call interviews with the women, their hospital records, and also we worked hand in hand with the billing center, the Greater Accra Regional Hospital to come up with this cost data, because we couldn't just entirely rely on the estimates that were given by the women. So a quantitative and descriptive estimations was done in Stata to come up with the direct and the indirect cost. And a post-estimation sensitivity analysis test was done to see the robustness of this study that we came up. So one way we looked at the various costs in the cost in the various years, and also we made some variations with the cost component to see how they differ from the base result that we had. Ethical clearance was obtained from the Institutional Review Board of the Institute of Statistical, Social and Economic Research at the University of Ghana, and also the Ethics Review Committee of the Ghana Health Service. Next slide, please. So to our results, a total of 121 women were finally recruited in this study, and with the by classification, 57% were diagnosed with preeclampsia, 18.2 had eclampsia, 7.4 had gestational hypertension, 2.3 were diagnosed with chronic hypertension, and about 15% were diagnosed with superimposed preeclampsia and chronic hypertension. So from the estimation we made, the overall economic cost of HDP associated with HDP amounted to 6,077.21 Ghana cedis. That is to say that on average, if a woman is diagnosed with preeclampsia, from the point of diagnosis till delivery and discharge from the hospital, this is the cost she incurs in terms of the economic cost, which I outlined in our framework what went into it. And look, we looked at the direct cost and the indirect cost. So the direct cost accounted for about 84% of the total cost. And out of the components we did in the direct cost, we looked at the medical and the non-medical cost and realized that a large portion also went to the medical cost. That means they spend a lot at the hospital receiving care. The direct cost, the out-of-pocket payment that they make, that was about 4,434.74 Ghana cedis. And the indirect cost was around 973.36 Ghana cedis. Just to note that this USD equivalent we used was $1 to 11.62 Ghana cedis, which was the official rate as of November 2023. Please, the next slide. So with regards to intangible effect assessments that we made, we couldn't really quantify, but then some analysis and discussions we made around. Talking to the women, we realized about 42.2% of these women were severely burdened by the condition, psychologically, emotionally. We asked them general, from their perspective, what do you think about how burdened you were? So we gave them the various sections, categories to choose, and this is what we came up with from the women. Specifically, about 77.7% mentioned that they could not engage in their routine activities before the complication came up. Also, 62.8% were afraid of losing their lives and their babies. This went a long way to affect their quality of life and productivity, because you realize some women even left work before. Women who had previous conditions stopped work early before the doctor could diagnose them, and this was losing value for time. I mean, they left work early, so that was loss of income. So comparing the test results, I mentioned a post-estimation test. We saw that there were consistent results with the modeled increases that were made to the cost component, so we could trust these results he came up with. Next slide. So some few discussions and conclusions we want to make around this study. We're saying that generally we've realized that HDPs are associated with relatively high healthcare costs, right? And from the calculations, estimations we made, we saw that the economic cost was about 1.8 times larger than the average monthly household expenditure that was estimated in the study. That was around 3,368, and that was a huge burden for the household. Also, HDP was seen to result in direct loss of income to the household through the loss of productive days. So as I mentioned earlier, most of these women were involved in informal jobs, and they earned by being present at work. They earn by providing service at work, and not having the luxury to show up due to these conditions took away direct income from the household. Also, participants explicitly expressed worry for the high medical bills which kept accumulating. So some of the women went ahead to suggest that their anxiety rose, and they think that even contributed to their rising blood pressure than whatever other medical condition was in, because we were worrying about the cost that they were incurring. Sleeping in the hospital from diagnosis to delivery, she's calculating the admission days in her head, and this is rising her pressure. All these things came in. Also, we realized the household adopted various coping mechanisms, and this was seen in different studies. We realized that when things happen like this, so from this study, about 59% of participants borrowed from distant relatives and took loans, which came with interest. So after caring for your child, they had to take loans to foot the medical bills. And aside that, some are still in debt, as at the time we're taking the study, and still paying off what interest. So we realized the household adopted a very strategic coping mechanism where they made use of non-working household members. So I believe that helped the indirect cost to be lower, as we saw, because non-working household members took up the caretaking job. So those who were working could go to work and still earn something for the household. So as I said, we can see this in other studies, which a few I have mentioned on the slide. So the next slide. So some limitations we encountered I want to highlight was the recall bias during the interviews, right? But because of the different sources we employed, from the hospital records and also going to their records at the billing center to know how much they paid. We didn't just take it by word of mouth. We worked with the billing center. We had their consent to go into their cost data, and by doing that, we were able to address some of the recall bias that came up during the interview. Also, the possibility of selection bias, which some women had very adverse outcomes. And so they didn't want to relive the moment. So we had some of them self-selecting to not continue the study, to participate in the study. I remember specifically one woman mentioned that she thinks she doesn't want to go through, she lost her child, so she just doesn't want to talk about that episode again. This made us load some data that we could have also gotten from that side. Please, the next slide. Yes, a few recommendations we would like to make. We know a lot of recommendations are going on. We hope that it won't just be said by me, but some action will be taken, right? So we were saying that stakeholders should identify ways to address the economic burden. For example, a comprehensive or an additional health insurance for these women, a social protection to cover direct and indirect, or a medical to cushion them during such challenging periods. It's not just health, but there is psychological and economical challenge they are going through. So some cushion could be made for them to support them during those periods, and also to prepare women for financial risks during antenatal. So we are saying that probably when household on average believe that they have 9 months to prepare for delivery. So sometimes there are households that say, I'm trying to save till the time you are ready to deliver, we have this amount. But conditions like HDP is distracting that you realize that you have to go to the hospital probably at 32 weeks and you are being presented with this complication. You are told that it's severe, we have to deliver the child. I'm saying it this way because this was something I literally saw at the hospital when I was taking the data. So I just wanted, and it was, she said she would go home with the child. That is what she said. So the doctors had to persuade her and keep her. So all of these are some of the things that households could be prepped earlier during antenatal, even before diagnosis, so they can prepare economically for anything. And we are recommending a future research, probably a comparative study on the economic burden of normotensive and hypertensive studies. I think it will be interesting to know the impact that is felt by people, so that we can compare and know how much this impact is, being on the households that have been affected. Other suggestions could also come from the audience. Knowing what we've come up with. So this was just a few references that we used that I wanted to show, and a few acknowledgements. I just want to say a big thank you to my supervisors and collaborators from Sports Study, Dr. Brown, Dr. Manos Sofenyo, Dr. Joyce Brown, Dr. Ahimfo, and some supervisors from the Economics Department, and the staff at the Billing Center at the Greater Accra Regional Hospital. They were tremendous. It was an individual task they did, and it was very good. And all the members of the Sports Study, thank you so much.
I can see you clapping. Great appreciation there. Later, please. The appreciation continues. Thank you. At this point, would invite Ms. Dora Van to give us a very great presentation on informing a national research agenda for the management of hypertensive disorders of pregnancy in Ghana, a priority-setting partnership. The appreciation. This one is pre-appreciation.
Thank you so much. Good morning, I think still, everyone. My name is Dora van Dijvenijk. I'm a Dutch medical student, and I would love to present something about our ongoing research project to you today, called Informing a National Research Agenda for the Management of Hypertensive Disorders of Pregnancy in Ghana, a priority-setting partnership. And very similarly to Dr. Hannah Brown, we're still doing this research right now, so I'll mainly go into the methods and not too much into results. So a similar disclaimer for me. Thank you. You're supposed to not see the whole slide yet, so please ignore the bottom part. So I think everyone here in this room thinks that research is very important for the improvement of care for pregnant women. Otherwise, you wouldn't be sitting here. So I wanted to invite everyone to briefly think about the question, who decides what we research and who should decide what we research? So please don't look. Or otherwise I'll share. So there's a series of articles from The Lancet where they went into this. And they come up with three main drivers for research agenda setting in biomedical research. The first one is economic forces. So then you can maybe think about the pharmaceutical industry, for example. The second one is governments and politicians. They also have a lot of influence on research agenda settings. And lastly, there's the academic community, where people also have a lot of maybe conscious or even subconscious preferences for research topics. And these stakeholders are not the ones that are directly involved in the condition that they're that is being researched. Actually, the ones, the end beneficiaries of research are only rarely involved in the setting of research agenda, as the authors found. And the end beneficiaries we can see as the patients and survivors of the condition, and also the healthcare professionals. And this phenomenon in total leads to sort of a waste in research investments. It leads to not the kind of improvements in care that you would want to get from research. And this is a staggering amount of about 85% of global research funds being wasted. Next slide, please. So that is one of the main reasons for the setting up of our project, which is called the Hypertensive Disorders of Pregnancy, so HDP Priority Setting Partnership, PSP. And with our project, we aim to inform a national research agenda for HDP in Ghana based on the priorities of patients, and also survivors, their caregivers, so for example, relatives, their husbands, and also close friends, and clinicians, and that is basically any type of healthcare professional from physicians to community health nurses. Next slide, please. The term priority setting partnership was invented or put forward by the James Lind Alliance, or JLA, and that is an initiative from the UK which basically created a method to set up research agendas based on the felt needs of patients, carers, and clinicians. And then being a UK-based organization, of course, this method was set up from a very global northern perspective, and it's also mainly been used in high-income settings so far. So to make sure that our process project fits the Ghanaian context or any lower middle income country context, we decided to combine the JLA method with an ethical toolkit that was developed by Dr. Bridget Pratt. And we, as a project team, used that toolkit throughout the whole research project to see which things from the JLA might fit and
So you have to write for the patient to go and buy. Sometimes they bring it and it doesn't contain the required amount. And if it comes with other supplement, as in other multivit, as in vitamins, do you still go ahead in case this person will need like 1.5 because of just the calcium component? Do you still let the person take it TDS, or how do you go about it?
Please, Doctor, we want to take the last question and then you respond to all of them. Thank you very much.
Please, my questions or my clarification go to the doctor. Please, you made mention of IOL for matured pregnancy. Please, sometimes when you give, you start the IOL, you see that the BP is shooting or BP is going high. Please, can I know if when you do the IOL, some of the cervix is not ripened. So for that one, can we do the IOL or send a person for cesarean section? Thank you.
The dose of calcium. Yes. Thank you very much. for the questions. The first question is about the dose of calcium. Sometimes calcium does not come as calcium tablet, but you have direct calcium. It may come with vitamin D, but it's quite available. So if you want to give multivitamin to the patient, please do and give additional calcium dose separately to the patient. Those ones normally comes in a minimum dose of about 500 milligrams, which is 0.5 grams. So when you have these, then you can make a decision. If the person is low risk, give one morning, one evening, which is 1,000 milligrams or 1 gram. You see, but not to give it as part of a multivitamin, because you might not be able, you may have to then give about different preparations of calcium in the market. So just write it up, calcium, and then the patient will get it and come back and show you. And then you look at the dose and make sure that it is the appropriate dose. That is what I can say as far as that is concerned. And the other question has to do with, we are going to dwell on induction of labor in women with preeclampsia. So I want us to leave it here. So at the parents, try and be at the severe with preeclampsia. Yes.
Humbly invite our dear.
Sorry for the long cliffhanger, everyone. Could you please go on to the slide of the project team? Yeah, perfect. So I think I introduced Jeffrey. And then we also work very closely together with Koiwa, with the three of us, basically to do justice to the local setting here. And our team is supervised by Dr. Dorothea Obiri and Dr. Joyce Brown, and all 5 of us are also here today. And I would also like to acknowledge Dr. Manuel Strofenio for also his help as a co-investigator for this project. Next slide, please. Just to give you a quick overview before we go into the details, our PSP process consists of 4 phases. The first phase mainly consisted of stakeholder analysis and engagement. Then the second phase really served to identify as many research uncertainties as mainly consisted of stakeholder analysis and engagement. Then the second phase really served to identify as many research uncertainties as we could. And for that, we held a survey, and right now we're analyzing the data of that survey. So then we go on to phase 3 next month, where we will prioritize these research uncertainties. And that will also happen through a survey. And then lastly, in August, we will work on extensive dissemination of our research agenda. Next slide, please. So to go into phase 1 first. So I just said that mainly consisted of stakeholder analysis and stakeholder engagement, and specifically in the form of establishing an advisory committee. And this committee consists of 14 members that kind of together fully represent the populations that we want to hear the voices of for our research agenda. So it mainly consists of patients or survivors, actually. But then also we have a husband, a relative of a survivor. Then we have clinicians, of whom actually one is also here in the hall with us, Dr. Bempa. But we also have midwives, community health nurses, then one obstetrician who's also a policymaker, and a queen mother to represent the women in her community. And this advisory committee comes together once per month, and we also have a WhatsApp platform with them. And there they give their input on basically everything that we do. We just discuss everything with them and make sure that it really fits the perspectives and the views, the needs of the populations that they represent. In the JLA method, the advisory committee kind of does all of the work. It's kind of the executive committee. But we decided to sort of deviate from that because, with the resources that we have and in this context, we just can't ask that kind of time investment. So we try to minimize the time investment that we ask while still getting all the perspectives from the advisory committee as needed. Then phase 2, as I said, that started with a survey where we asked, that's not a term that everyone understands, of course, so we asked for the questions and concerns that people have about the management of high blood pressure disorders of pregnancy. And that's specifically in the fields of diagnosis, treatment, prognosis, and causes and risk factors. And then on the mobile phone, you can also see that we also noticed again that the JLA focuses a lot on this through phone call, for example, and through in-person administration in all 16 Ghanaian regions. And yeah, there's respondents across different educational levels, across different professions, but it's a bit too much to go into everything in detail right now. So next slide, please. So these 292 respondents in total asked 813 questions or concerns about HDP. Healthcare professionals asked, how do we ensure that patients take their drugs on time, fetal and maternal health outcomes? So right now we're in the process of interpreting these questions, organizing them, reformulating them, with a lot of help from our advisory committee. And then we will review the existing literature to see whether the questions they asked are actually unanswered by research so far. Many stakeholders to discuss all day. But the research agenda is of course not the end, because we really need to make sure that help us turn this research agenda into actual problems and improvement of care. Next slide, please. So that brings me to my last slide, which is a call of action to you all, because I'm looking at a room full of healthcare professionals and probably also some survivors of HDP. So my first question to you is, please, interested to become a partner, please don't hesitate to reach out. We'll be very, very happy to see what we can do for each other as well. So there's my contact information, but it's also in the brochure. So you don't have to get your phones out right now. So yeah, that's kind of in concluding this. I really hope that you will all get involved so that we can bring the voices of patients, carers, and clinicians into HCP research. Next slide, please. Thank you all for your attention. We have some nice pictures on the last slide, so it would be nice to show it.
Thank you. Please, we'll take the questions later. We'll just have the next two.
Thank you very much. Now with us to support the activities of APEC. So we have some T-shirts here. If you need some, you can contact the protocol team. One goes for 200 cedis, but that one you can get it. You contact them, and you also have a sheet going around. You can put down your name and your contact number. We'll reach out to you at the right time so you can support the wonderful work of APEC. Thank you very much. So then take the questions and then we'll go into the various sessions. So please, let's take 2 questions from the presentation. Comment, contribution.
Okay, thank you for your Thank you for your contribution. So I think you're talking about the first slide where we mainly focused on the 3 parts that are currently driving research.
But I think that you should be mindful about some key points. And perhaps if you answer my question, then we would all be together. This research agenda you're talking about, are you talking about a national research agenda or future research agenda for sport team? Because if you are doing a research agenda on preeclampsia for the country, then we need many people at the table. And I'm not seeing that at all. And I understand the scope of your work, so I would think that you should keep it in the way that doesn't lift people's ears, so to speak. I mean, Director of Family Health is here. And if you are doing research agenda for preeclampsia in Ghana, she should be around the table.
Of labor, the discussion Dr. Shofenyo will be leading. Induction of labor for women with hypertensive disorders of pregnancy, a prospective cohort study. So that will be happening upstairs. Another, opposite this room, we will have the other session that will be equitable transdisciplinary SRHR research, productive challenges and joys. So that one will be happening opposite the other room upstairs. Then we'll have in this room, we'll have the presentation or the discussion on iatrogenic fluid overload. It's a prominent cause of pulmonary edema among women with pre-eclampsia and eclampsia. Urgent need for fluid therapy protocol. So we'll have that discussion in this room. If you registered online and you chose a topic already, just try and find which room that you have been. But for now, we are going to number, isn't it? The students, so that they can choose, they can be divided equally in the room, so in the 3 rooms. So that is what we'll do. So for those who registered online, please let's start moving. Then we'll bring the students up very soon. Yes. 40 minutes. The 40 minutes. 60 minutes. 1 hour. Okay, it's very important. 1 hour. Okay. So we have, if you have a preferred topic, just move to that room. Yes, if you have a preferred topic, just move to that room. But so please, let's move. The students, just wait. We'll quickly divide you. Hey, where are the ones?
We want to reduce it to 40. We have plenty to talk. 60 minutes. Yeah, deputy. No, we'll make it 60 minutes.
Okay, good afternoon, everyone. You are all welcome to this session. We are going to discuss Okay. The panel members are Dr. Atta Owusu Bempa. He is the head of department, maternal and fetal medicine unit, head of unit, maternal and fetal medicine, Komfanochi Teaching Hospital, and then Ghana College of Physician Surgeons. Please, doctor, let's see you. Please, this is Dr. Bempa. And another panel member will be Dr. Labi. Dr. Labi is the deputy medical director at Komfanochi Teaching Hospital. Please, let's see Dr. Labi. Thank you, Dr. Labi. Then we have Dr. Betty Anani Fenin. Dr. Betty Anani Fenin, please, also a member. Okay, she is the head of unit maternal and fetal medicine of Cape Coast Teaching Hospital. Cape Coast Teaching Hospital. Please, let's clap and welcome her. Then we have Dr. Yao Genta Owusu. He is a clinician. So he's a lead clinician at Obs and Gynae department at Komfanochi Teaching Hospital. Please, let's welcome him as well. All right, so we have 1R. Dr. Bimpa insists on the 1R, so we are going to have it. Okay, so let's welcome them all and then invite them to make the presentation, and then we'll have the discussion. Thank you very much.
Thank you very much, and good afternoon to everyone. Yeah, we have a lot to talk about. This is a topic which is so dear to some of us because it's causing a lot of maternal mortalities. So this is an audit, a clinical audit that was done at CAF from January to July of 2022. And I'm speaking on behalf of my co-authors. I think Dr. Esmonofori was somewhere here. Yeah. And then Dr. Owusu Jante, you already heard about him. And then Dr. Randolph will not be here. And I'm sure Dr. Dassan, who is also with the School of Public Health, will join us very soon. So, next slide. So, I'm going to just give an overview of how pulmonary edema occurs in preeclampsia and why we think we are having a lot of issues with fluid overload. And then the panel members will come in, and then subsequently will allow the audience to also ask questions and also give their contribution. So we know that preeclampsia is the most frequent hypertensive disorder of pregnancy globally, and it complicates about 2 to 8% of all pregnancies, and in fact accounts for 14% of maternal deaths and 12% of perinatal mortality. I mean, we've been back and forth with definition, and most people always tune their mind to proteinuria, and I said no. So this is one of the best definitions that I like, and it's new onset hypertension that has developed at least 20 weeks of gestational age, plus at least any one of these. Proteinuria, of course, but it doesn't have to be proteinuria by all means. And then any maternal organ dysfunction. So it could be neurological, pulmonary edema, hematological, liver involvement, or acute kidney injury, and or uteroplacental dysfunction. So this is the ESSEP criteria, even though some of us have issues with the last criteria, that you may have IUGL sitting somewhere and develop BP somewhere, and then you say it's preeclampsia. But that's a topic for another discussion some other time. The burden of this disease is enormous in low and middle income countries because preeclampsia is estimated to be about 7 times higher in our setting. Yeah, next slide. So prevalence in Africa is noted to range from 1.8 to 16.7%, and in Ghana, most studies put it at just around 8%. And you go target of reducing maternal mortality ratio to 190 per 100,000 live births by 2015. Despite a 34% decline in MMR from 2000 to 2020, with a national model estimates in 2020 around 263 per 100,000 live births, we still know that the current annual decline rate of 2.1 is just 1/3 of what we need to meet the SDG target of 70 per 100,000 births, which is 6.4. So we are still crawling. And Ghana Maternal Health Survey in 2017, and at that time our MMR was 308, reported that approximately 18% of maternal deaths were caused by preeclampsia versus 30% for obstetric hemorrhage. The situation is different from the referral hospitals and teaching hospitals that take up bulk of these referrals. Because it was noticed that 50% of maternal deaths in Ghana actually occur at tertiary hospitals, because tertiary hospitals receive these complicated cases. And preeclampsia, not obstetric hemorrhage, is the leading cause of direct maternal mortality in these hospitals. Next slide. So as far back as 2008 to 2010, an audit of maternal mortality at Komfo-Anokye revealed that hypertensive disorders of pregnancy, actually preeclampsia, was the leading cause and not obstetric hemorrhage, and that was around 26.4%. Next slide. And it's always good when you are doing a presentation. Some of the authors are sitting here. So Prof. Opon is here. Next slide. Because a 5-year survey was also done at Kolebu from 2015 to 2019. And it was also obvious that the leading cause of maternal death was hypertensive disorders. That was at 37.3%. And Komfo-Anokye's latest data, if you see it, next slide, our audit of 2023 maternal mortality. The whole year was about 104 maternal deaths, which is huge. And because of the peculiarity of Komfo-Anokye's location, being at the middle belt and taking referrals from all over and being the only teaching hospital also around. Unlike in Accra, I'm also envious about this. I mean, my only problem, if you see later on, is that we are not subcategorizing the actual final pathway to maternal mortality. So you see us writing eclampsia. You can have a woman who would suffer death, having suffered eclampsia, but die from pulmonary edema. So the final cause of death is actually pulmonary eclampsia complicated of pulmonary edema. But we seem to put everything under eclampsia. And then intracerebral hemorrhage is also missed, because we always say, and then you can have aspiration pneumonitis, aspiration pneumonia, leading to Madelson's syndrome and causing death. So we put everything together, and then we think that's an issue. Because it doesn't give us a broader view of how we should address the problem. Next slide, please. So these are some of the immediate causes of hypertensive disorder in pregnancy-related mortality. You can have cardiorespiratory arrest, which of course will happen in eclampsia. The death could also result from acute kidney injury, could result from intracerebral hemorrhage. But intracerebral hemorrhage could be as a result of seizures, coagulopathy, thrombocytopenia, and or severe hypertensive episode. And then the death could also result from liver dysfunction or hemorrhage. Example is abruptio or coagulopathy. Or it could be from metabolic and electrolyte disturbances. So as you realize, we stop saying that cause of death is preeclampsia, because we know the final pathway that led to that. And of course, the one we want to dwell on today, which is pulmonary edema. I mean, if you go to South Africa, because I've practiced there for 2.5 years when I was doing my program, the commonest cause of death in preeclampsia is actually from pulmonary edema. And the intracerebral hemorrhage is second. It's not eclampsia. Because you can have eclampsia and what is resulting in death is pulmonary edema or intracerebral hemorrhage or cardiorespiratory. So there's also this paper from Sports, and we all know APEC is an affiliate, and I always say I'm happy when you put a paper and you see authors around. So Prof. Bonsafo is here. Give us a wave. Right. I mean, they also did a study, and they realized the organs that are commonly affected are the brain, which is eclampsia, hematological, which is HELLP syndrome, and then respiratory dysfunction. So what they didn't classify, which I think most of them were pulmonary edema, was under the respiratory dysfunction. So if you have SOB, just means shortness of breath. So shortness of breath or breathlessness secondary to pulmonary edema is actually one of the predictors of severe maternal outcomes in preeclampsia. If you have pulmonary edema, then there will be interference of gas exchange, and that will lead to hypoxemia, hypercapnia, and of course, multiple organ dysfunction. You can have pulmonary edema, subsequently AKI, because of the hypoxemia, and then you may think that the cause of death is actually AKI. So we have to have a way of collecting our data very well. And I'm sure that's what South Africa is doing very well, and they are able to know that pulmonary edema is actually the leading cause of mortality when it comes to preeclampsia. Because it's one of the predictors of SMOs in preeclampsia, any time it should be considered an indication for referral to a specialist hospital. So if you have a woman of shortness of breath in preeclampsia, I want to tell you it's not a mistake that the differentials are jumped from 1 to 3, because the first differential is pulmonary edema. Second differential is pulmonary edema, before you think of other possible causes, which can be from cardiogenic cause or non-cardiogenic cause, as listed underneath. Next slide. Pulmonary edema in preeclampsia, and it's multifactorial. Development of pulmonary edema would definitely depend, if you all remember our physiology long time ago, would depend on hydrostatic pressures in the pulmonary capillaries, the oncotic pressure holding fluid in the intravascular space, of course, the integrity of the endothelium, and also the lymphatic system draining fluids from the lungs. So in preeclampsia, possible mechanisms could be because there's increased risk, there's increased vascular permeability from the endothelial dysfunction in the pulmonary capillary bed because of the cardiac dysfunction. Next slide. So most common PE is actually the most common cardiopulmonary complication in preeclampsia. And it's even higher, or the risk is higher, when the woman develops AKI, oliguria or anuria, HELLP syndrome, and acute cardiac impairment. Also, it may occur from unrestricted fluid administration, and this is where our interest is most. And that is why fluid therapy in preeclamptic is challenging, because we know that fluid restriction may precipitate or worsen ischemic kidney lesion, whereas fluid overload may obviously lead to pulmonary edema. Again, prior to epidural analgesia or IV antihypertensives, if the woman is yet to deliver and lung fills are clear, and I've bolded this one because it's one of the substandard cases we have in the system, then a preload of 250 to 300 ml of SROs is what is supposed to be given. But believe me, preloading, people are giving 1 liter in preeclamptic who have so much risk of developing pulmonary edema, and they are referred to us. So IV fluid administration must remain within a safe threshold, and strict input-output chart should be maintained. Next slide, please. So these are some of the considerations that we should have during fluid management in a woman of preeclampsia. We know how the pendulum may swing. If you restrict, we know there could be hypoperfusion leading to AKI. But then if you also are not cautious with your fluid, then you obviously cause congestion. And then this is to give 80 ml per hour so that you know you are giving about 2 liters in the whole 24 hours for maintenance if there is no AKI. Because believe me, if the woman is not producing urine and you've done fluid challenges over time, you cannot keep giving 2 liters. You shift her into pulmonary edema. Or you could just time urine output per hour and then add 30 ml per hour of insensible loss. Pulmonary edema, then, and you are doing restricted rate, BP, respiratory rate, such that you have to do replacement or resuscitation. Then you may need to do more than just your clinical monitoring. You may need to do transthoracic echo. You may need to do your pulse oximetry. You may need to do your lung scan and your intra-arterial catheterization for continuous BP monitoring. But that will be for the other extreme. And again, there should be early involvement of a nephrologist when there is AKI and you are struggling with pulmonary edema, so that when it's refractory to medical treatment, that will be an indication for renal replacement therapy. More often than not, there's so much delay because you'll be arguing with the nephrologist. You are pushing them to go for dialysis. So, what was the justification for this clinical audit? It's known from other studies, though outside Ghana, also factors for pulmonary edema. And in fact, fluid overload was reported as an underlying cause in as much as 21.5% in a case series from US and 13.3% from a case series in France. And this is even where they have guidelines. So you can imagine us. And then also from the spot observational study we just mentioned earlier, they had a maternal near miss of 33%, and compared to the maternal deaths of 2.7, it means that the ratio was about 12 to 3 times. So it means that if you have one mortality from preeclampsia, you would have had about 12 women with morbidities. That's what it means. And then the mortality index was 8%. And the conclusion was that appropriate interventions are required in order to improve care for women of HDP. We also have observed over time at Confanoche that we're getting more cases of shortness of breath in women of preeclampsia. And we know there's paucity of data in our setting. And we also knew by doing this, it will give us the chance to do future research to inform robust guidelines in fluid therapy. Next slide, please. Right, so this was a hospital-based review. I won't go into where CAF is and what CAF is. But the study population were women with shortness of breath that were admitted to our ICU high dependency A1 ward, which is purely for hypertensive disease in pregnancy. And I think I saw the A1 in charge here. Or she moved to another section. All right. And then also our high-risk A5 medical ward. I mean, the inclusion criteria were mothers with HDP who presented of tachypnea, autopnea, or desaturation, and also mothers who were diagnosed with medical conditions but were associated with shortness of breath. We also included women with HDP that had chest X-ray features or ultrasound features of pulmonary edema. Next slide. So excluded were cases of obstetric hemorrhage who will present with shortness of breath, but we know the problem is ectopic. We know ruptured ectopic. We know it's PPH. We know it's hemoperitoneum from during cesarean section. So they were excluded. And because we didn't include postnatal ward, we definitely wouldn't have included women that were admitted or developed ARDS from sepsis. So, I mean, we got the data from LEMS, and then we did our analysis. So categorical data were presented as frequencies, percentages, and continuous variables as plus or minus standard deviation for parametric variables. And then we represented the proportion of SOBs as a result of pulmonary edema and the other causes on pie chart, and also the proportion from iatrogenic fluid overload on pie chart. Next slide, please. Right. So, if you can move to the next slide, I'll come back here. Yeah. So overall, there were 100 and 170 patients that were admitted to the 3 wards involved during the period, of which 35 were for shortness of breath. So that gave us a proportion of 3%. And the common definitive diagnosis for shortness of breath was for pulmonary edema, that was 54%. Pneumonia was 5 out of the 35. Anemia 4. Acute exacerbation of bronchial asthma was 2, representing 5.7. And then other causes that included pulmonary embolism was 14.3. So you can go back to the previous slide, the pie chart one. Yeah, I mean, so this was how it was. Okay, you can move to the next slide again. No, go back, yes, fine. Yeah, so the SOB case fatality rate was 23%, that was 8/35, and including all 3 patients that were admitted to ICU. 15 of the reported pulmonary edema cases occurred in women of preeclampsia. So for the total SOBs, 19 were pulmonary edema, and out of the 19, 15 were in women of preeclampsia. 3 were cardiogenic, that's 2 cases of perinatal transfusion-related acute lung injury. Next slide. Right, so, I mean, these were patients that were being managed at CAF, not referred per se. And out of the 35 cases of SOBs, 10 of them were patients that were being managed at CAF, and then 3 of them actually suffered pulmonary edema. 2 of them, as I said, one was the MI, and the other one was the transfusion-related acute lung injury, and 1 was in preeclampsia, iatrogenic pulmonary edema. And then the other 25, 9, as high as 16 is what we are very particular about for this research here. Next slide. So if you take the red represents the iatrogenic fluid overload. And this is a patient. So out of the 3 pulmonary edema cases at CAF, 1 was MI, the other was Trally, and the other one was iatrogenic fluid overload. This, I'm sure it was a resident who was warm, having gone to read about edema that were referred as high as 10. The underlying cause was iatrogenic pulmonary edema. So overall, iatrogenic fluid overload being the underlying cause was 58. And if you compare it to the case studies from you, they have guidelines and protocols, and we don't. And this was as high as 58. And then even for the referred cases, it was as high as 62. That was attributable to iatrogenic fluid overload. Next slide. So the conclusion was that pulmonary edema from iatrogenic fluid overload is common among women of preeclampsia, referred for shortness of breath in our setting. There is therefore an urgent need to assess fluid therapy practice was iatrogenic pulmonary edema. So overall, iatrogenic fluid overload being the underlying cause was 58. And if you compare it to the case studies from US, that was 24. And I said they have guidelines and protocols, and we don't. And this was as high as 58. And then even for the referred cases, it was as high as 62. That was attributable to iatrogenic fluid overload. Next slide. So the conclusion was that pulmonary edema from iatrogenic fluid overload is common among women of preeclampsia, referred for shortness of breath in our setting. There is therefore an urgent need to assess fluid therapy practices among women of preeclampsia in primary and secondary level hospitals in the Ashanti region of Ghana, and to develop a consensus-based fluid management protocol to forestall iatrogenic fluid overload. And so, of course, we couldn't have accounted for misdiagnosis and missed diagnosis. And also, as you can see, the small sample size. So the next slide is where we'll bring in our panel members and factors that could be associated with iatrogenic fluid overload and tension.
Would sit there and then we'll have the discussion. So please hold your guns a few minutes. Panel members. Dr. Labi, Dr. Fenin, and Dr. Bimpo.
ICU, right? Most of the time, the cases that gets referred to us for ventilatory support, they will see at the peripheral hospitals then write that a patient's work of breathing is going up, so refer to Confanoche for ICU care, right? Most of the time, when they come and we assess them, it tends to repeat itself. You have a woman with preeclampsia, a patient's work of breathing is going up, so refer to Confanoche for ICU care. right? Most of the time when they come on max sulfate, a doctor rightfully prescribe IV fluids.
Thank you. Good afternoon once again. Thank you, Dr. Bempa, for that clear presentation, and also kudos to your team. I agree this is a very relevant topic, particularly in preeclampsia, where we know the predisposition to pulmonary edema is already high, and therefore we have to be very cautious with the fluids we give. But when Dr. Jante was talking, he spoke about giving IV fluids without not even stating the rate and the duration and all that. I think generally we've become a population of IV fluids. I'm sorry to say that, but it looks like every case we want to see at the emergency or whoever presents, we want to infuse some IV fluids. And it's probably also because of how our people perceive IV fluids. They love it when we give it to them. It shows how sick they are and the need for them to get that attention from their family and friends. You're born in too. So it's very interesting the way the patients think. So we've also developed that culture. Oh, give him 500, give her 500. So in cases of preeclampsia, if you are not careful, then you tip the woman into pulmonary edema. Another aspect that we sometimes overlook is the antidiuretic effect of oxytocin. We've already established that the woman is already predisposed to pulmonary edema. Sometimes we are compelled to set up oxytocin infusion to help with the contraction. But we forget that this oxytocin will also have fluid retention properties. Therefore, that fluid we are given must all be factored in, and the fact that the patient can also develop fluid retention from that drug, everything must be factored in. And it is also best practice that when you are giving fluids in such a patient, you should be very, the monitoring should be high. The simplest things you can do, just pulse oximeter. If you don't have it, it's fine. Listening to the lung basis in settings where there are doctors or PAs, it also helps a lot. Just listening as the patient, for example, the scenario Dr. Jante created, somebody is having fetal distress, and so you need to infuse some fluids. First of all, we've identified the problem that we don't even have a protocol for those settings. We'll come there. But even if you have to do that, as a clinician, are you at least listening to the very simple pointers that could tell you that your patient may be at risk of pulmonary edema or not? So I think it boils down to being cautious, being deliberate about it, and then tightening our monitoring skills. I'm sure the rest, my other panelists will also have something to say. But at the end, if my third point doesn't come out, I'll bring it out again. Thank you, Dr. Feni.
Dr. Feni, you've given all the IV fluids, so I don't know what to say. Yes. Just so they rushed to hospital 3 times in the last month, complaining of mekoma. And she did an eating at home. They went to hospital and they put IV fluids on her. And the problem was the fact that the woman was thinking about a second wife. Yes. Now, coming back to the substantive topic, SOPs are very important in every setting, and especially in our work. And when we are talking about preeclampsia, and we look at the mechanism of pulmonary edema, as we saw, the high blood pressure, so we've seen the afterload, we've seen what is happening in the capillaries, the capillary leakage, and so on, the low protein. So when we are the drug starts now, as part of our treatment too, we are causing this pulmonary edema. A couple of days ago, or 3 days ago, on the maternal referral platform, there was a case that was they were discussing. And one of the things I asked was, the patient had an HB of 4.5 and platelets of 45 in Mampong, and they didn't have blood, so they were referring this patient. And one of the questions that I asked was, I want to know the vital signs. They just gave me BP and pulse. I said, I want to know the SpO2. Then they said 92 on nasal prongs blood, so they were referring this patient. And I want to know the vital signs. They just gave me BP and pulse. I said, I want to know the SpO2 92 on nasal prongs. Okay, I said, okay. Do you have a non-rebreather? So we had to start working on that before sending the patient. I said, and ensure that you don't give...
Say I'm a magician. To know whether we are using it for maintenance, replacement, or resuscitation. There are 3 different scenarios. And then it's risk-benefit. There's no evidence. But membership, you need your marks. Otherwise, this guy will seize it. And we get a lot of them. Inappropriate fluid bolus prior to mark sulfates or vasodilating antihypertensive agents. So the midwives, if patient is not short of breath, you do your 250 before your mark, so we don't have a problem. But in patient, refusal to include or compute fluid volume used for drug administration or oral intake as part of the total daily intake. So we say 2 liters in 24 hours, fluid restriction, 80 ml per hour. And then this woman is receiving PMO. How much is 1 vial? What's the volume of 1 PMO? Is it 250 or 100? And you are giving TDS also, and you don't subtract it from your 80 ml per hour. Perioperative hypotension, as we said, rather than using phenylephrine or ephedrine. When you do neuralgia, anesthesia, and the BP drops, the anesthetists are now, they know that they can use ephedrine or phenylephrine so that you deliver small volumes rather than large volumes. And then missed opportunities in administering furosemide. I don't know whether that was the one you were going to speak about. In women who already have heart failure or pulmonary edema, whether from hypoproteinemia, and have an ASACA, and we know after delivery of placenta, there's what we call autotransfusion. Blood from the placenta, but about 500 ml will go back into the maternal circulation. So these patients require LASIs. And then non-availability of infusion pumps. So I wish the public health nurse, Dr. Kuhlman, was still here. And if we don't have infusion pumps, why can't we use Doxyflow? And believe me, one is 15 cedis, and the women cannot afford it. They cannot. But if we say we want to improve care, we have to do that. And then lack of robust monitoring tools for HDP, as was mentioned, requiring IV fluids. So next slide. Because we want to write so that we all take part in answering the questions, they also have to have their say. The way forward is that to err is human. Standardization of care for women of HDP, including fluid therapy protocol, is needed in order to prevent avoidable maternal morbidities and mortality. There is a need to evaluate gaps in our fluid therapy for these cohorts of women. And we need to have a consensus approach to develop guidelines for fluid therapy in women of preeclampsia. So MFM units at CAF and some MFM specialists at Menchia and Jacobu, we have a concept paper. The protocol is already done on assessment of fluid therapy among women of preeclampsia, eclampsia in primary and secondary level health facilities in the Ashanti region. I mean, later on, it can be copied in the other regions. And it's a mixed study. Next slide. So, I mean, the research questions are, first, what is the knowledge of healthcare providers on fluid therapy regimen for maintenance, preloading, and resuscitation in women with preeclampsia? And then what are the gaps in fluid therapy administration amongst women of preeclampsia, eclampsia at these selected facilities? What are the means or tools for monitoring fluid administration? What is the knowledge of nurse anesthetists or anesthesiologists in preventing or managing hypotensive episodes complicating neuralgia anesthesia in such women? And then how can we develop a consensus-based protocol for fluid management in women with preeclampsia in our setting? And I have some of our MFN specialists working on it. Dr. Timothy Ajay was here. I don't know whether he went to the other section. Dr. Ope from Menchia and some colleagues from Komfanoche. Protocol is almost done. And we realize we need sponsorship. So we are pushing. We are going to get some people involved. We'll do about 10 health facilities, assess, and then come up with protocols of their involvement. So the aim, I mean, we've already stresses that we want to assess deficiencies and gaps in fluid therapy in pre-eclamptics in these facilities.
That have a very severe form of pulmonary edema. Sometimes so bad. You pass the ET tube, you literally have to suck out the fluid, and it comes out like a pipe that's flowing. We have noticed that for those clients, the moment you pass the ET tube, a few minutes later they arrest. I would want some take on that as well. What else we could do beyond having to intubate them? Because you look at the respiratory rates, obviously they are exhausted from the effort they are putting in. They are definitely going to arrest if you don't intervene. So what do we do in that scenario? Thank you.
I think for the first part, we also do NG fluids, but the only
your usual things you do, it calls for an early dialysis because it's also a means of decongestion the body of fluids. All right.
I'll add just a little bit to what Dr. Jante said. If you have the luxury of an intensivist, then that is where probably the use of drugs like dopamine or dobitamin will come in the scenario he created. But if definitely you have the access to dialysis, then yes, you could also utilize it. But I think every doctor working in the peripheral facility, every obstetrician needs a bit of training in intensive care.
I wanted to add to, because you in one of the cases, scenarios you talked about people who arrest soon after intubation. And I want to believe that before your intubation, you had everything prepared in anticipation of a possible arrest, because you are dealing with a patient who is very unstable. So when we are going to do that, even with patients who don't have any problem, we need to be prepared. So the teamwork, your anesthesiologist and everyone else who is important, and it should be there, and make sure you have all your drugs available. Okay, so that if the person arrests, you know what to do. And then what we call, we don't do drills in Ghana. So we get into a problem, and then things are not moving on. We are running around. So once we know, it's something we need to do in all our institutions. In Konfanochi, we don't do drills. It's something that we have to do a lot, right? So that once you know someone can arrest, and we've done the drills, and we have all the things ready, when the person arrests, we know what to do. And once we know what to do, we improve the chances of getting the person back. Thank you.
Okay. Yeah, so thank you for the opportunity. I am excited to actually know that KNUST and CAT, they are trying to consider fluid management, because this has been a very long-term problem. I think some time ago, Dr. Bempa presented at the Ghana College, and I have also been working on preeclampsia, so it has been a very big issue. But one thing I want us to remember is as part of the pathophysiology, is the leaky capillaries. Their capillaries are leaky. So when you see somebody who is edematous, consider that edema somehow is also occurring in the lungs. And so we have to be very careful. And I remember a long time ago when I was a resident, and the late Prof. Hubert mentioned that we forget also that these people have hypertension, and they are probably also having heart failure. And we forget that. And so you give your fluid and you make things worse. Already leaky capillaries, you compound the problem. The other thing we used to do also was the use of hydrolyzing. You use hydrolyzing, it causes so much vasodilatation, more fluid retention, and you get fetal distress. And once you get fetal distress, you want to do more fluid, and you make things worse. And so knowing that hydrolyzing can actually cause severe hypotension from vasodilatation, we decided that sometimes that is not probably the best to do if you want to give it to a patient. And more so, in that case, probably then labetalol will be a point, something that we should consider. So just to add that, I mean, leaky capillaries is one of the main things that we have to consider, and the other complications. But when Dr. Bempa mentioned the fact that we talk of underlying factors and forget the pulmonary edema, you are right, because 2013, Professor Pond, myself, and other co-authors did work on maternal death attributable to hypertensive disorders of pregnancy. Yes. All right. So then you started that one. Then you realize that, of course, when we finished the paper, most of them, about 23%, was due to eclampsia. We realized that no, eclampsia cannot be a cause, but of course, for that time, or at that time, that was it was a retrospective study, and that was what people had indicated. So we discussed it and said, that's all we have. We can't infer from, the information we have, so we put it there. But pulmonary edema actually caused about 12, nearly 13%. And AKI was about, I think, 20% or so. So, exactly. So if you combine that 13 plus 21%, you can consider that we are talking about nearly more than a third of people having had a pulmonary edema. So we are excited that this is going to be done, and we look forward to seeing the results and how it's going to play out, and how it can also help change or influence the protocol for Ghana. It looks like we don't really have something like that. And I have a little comment on whether to use the weight or the straight jacket of the 80%. It can be very confusing and dicey because, by the time they come and they are heavy, edematous, their weight, and we all know that weight can increase suddenly, even though it's not part of the diagnosis that has been removed. But that weight may be so high that if you want to use that to give fluid and increase and give more, then you are going to rather compound the issue. So it's quite pre-pregnancy. All right, pre-pregnancy is something that you don't also get, because even that's what the anesthetists will want us to use, isn't it? But we don't normally. Yes, that can be used for that. But here in Ghana, I think we have about 64% of people booking the first trimester. That can probably help us. We have a lot of them who are not booking. So, just to add to that, so I think on that point, what will supersede everything will be monitoring. Yeah, monitoring. If you are doing 8 ml per hour and you are monitoring, yeah. Respectively, the woman has a small size, you will still pick. Exactly. Yeah. So from the Ghana Maternal Health Service, I think about 64% of women actually book within the first trimester. The rest don't, and they go and come. So I think in the protocol of writing the guideline, we should also consider timing of delivery. We shouldn't, can we deliver? And so I'm very happy to be God. Thank you.
Thank you very much, Prof.
Okay, thank you for the opportunity. I am not anywhere with my students. I'm a teacher. Yeah, but I've learned a lot from pre-eclampsia. I didn't know how serious things were with that.
All right, let me answer our sister's question. We have what we call some criteria. And if you have more of them, then you have to start aspirin from about 13, at least by 16 weeks going. Or if you have one of them, even be a sign of gestational hypertension. And gestational hypertension too is also a risk factor for hypertensive disorders, preeclampsia. So that is it.
So yes. I was surprised that you said you are not a health personnel, but it's actually coming from a publication that I've read before. You get a point. And there is this concept that we want to do about AI in predicting people with higher risk of preeclampsia. And Dr. Pond is involved in one of such study. There's one such study that we are working on, but the founders say they want KNUST to establish Center for AI before they will do it. So Dr. Dasa and Prof. Phyllis are working on that. Okay, we are telling us. So there's something we know, and there's one organ system I respect very much because of prayer. Endothelial dysfunction. It can lead to so many things. That's what Dr. Labi was trying to say, mention when he said obesity and the rest. They all fit into metabolic syndrome, which will eventually lead to endothelial dysfunction. So if you have a family history of hypertension, yes, you have a risk. Okay, but we don't know, we cannot quantify that risk now. That's why we are in process of building AI to get that predictive value. You have advance in age, yes, it is. And then if you've had a previous big baby, it means that you had certain factors. That's why your baby was big. And it fits into all those cardiometabolic syndromes we are talking about. So they all cause endothelial dysfunction. And I'm sure you might have read or listened to something, because there's a publication to that effect. Thank you very much.
She had a last question about doctors telling or advising patients to. I think that it all boils down to counseling, all right? You should understand the risk involved, your high risk of developing preeclampsia and the risk involved in the preeclampsia. You must understand. I haven't really come across a clinician say, don't give birth again. No. But I will approach it from the point, you've said it before, unless there are medical conditions, let me state this, there are medical conditions that are outright contraindicated in pregnancy. Those ones I understand, but I haven't seen for preeclampsia per se that because of that, don't give birth again. It's counseling. If she understands it that way and she makes an informed consent, I am not going to give birth again. I'm not going to get pregnant. The reduction rate is around 60%. Okay? That is when you develop your risk of developing the preeclampsia before the 37th week. All right? We can reduce it by about 60% by these models. Dr. Janta is going to dwell on a lot of it, and Dr. Prof. Opon too is going to talk about it very soon. So don't give birth again, no. But I will approach it from the point, you've said it before, unless there are medical conditions, let me state this, there are medical conditions that are outright contraindicated in pregnancy. Those ones I understand, but...
Right issue. So who is that doctor saying, don't give birth again? It's equal to cause. Fluid therapy is usually crystalloids. Normal saline, ringer's lactate, blah, blah, blah. Where you will expect that you give 3 times the estimated amount of blood loss. But imagine the woman has lost 1.5 liters. It drowned the woman. So we should think of crystalloids, we should think of colloids early, and we should think of blood replacement early. Because And there are concerns of the risk of postpartum hemorrhage, which might be greater with higher doses of aspirin. And therefore made this statement in 2021 that they think that selected 75 milligram, they think that 75 milligram may be the recommended dose. However, they acknowledge that comparing 75 to 150 milligram should be a high research priority. Next slide. So based on that research recommendations, the Pearl study idea was conceived. And Pearl study or Pearl trial stands for preventing preeclampsia, evaluating low-dose aspirin, low-dose regimes, following risk screening. So what this study seeks to do is to answer three questions. One, can we correctly identify women at high risk of preeclampsia? Number two, comparing 750 and 150 milligram of daily dose of aspirin starting before 20 weeks. Which of these two doses will be most effective or most efficacious in preventing preeclampsia within this population? And another important, the last but not the least important, is to identify the safety profile or to determine the risk of postpartum hemorrhage associated with these two doses of low-dose aspirin. Next slide, please. I think I've talked about this one. So essentially, what you need to just go back, please. So essentially, what you need to we are seeking to the question we are seeking to answer is 150 milligram daily aspirin more efficacious and sufficiently safe compared to 75 milligram per day aspirin to make a definitive policy decision to use a higher dose? Next slide. Next slide, please. Okay. All right. So why is this study important? This study is important because it will be the largest preeclampsia trial anywhere in the world. And most importantly, a largest preeclampsia trial that includes Africa. In fact, this study does not only include Africa, but this study is going to be done only in Africa. Remember, blacks have a 2 to 3-fold risk of developing preeclampsia compared to Caucasians. So if you need to find a solution to this preeclampsia problem, that solution must take, part of the solution must emanate also from Africa. And we are going to randomize over 20,000 participants from 3 countries. For the first time, we are going to objectively measure blood loss after vaginal delivery following the use of low-dose aspirin for preventing preeclampsia using calibrated drips, so that the blood loss as determined after delivery is not based on visual inspection, because we all know the challenges associated with the use of just visual inspection. And again, the rationale for this landmark study is based on a WHO recommendation to find a lasting answer to the question 750 or 150, which one is more efficacious and which one is associated with more side effects. Next slide, please. So this study is taking place in 3 countries, in Ghana, in Kenya, and South Africa. And Ghana is being hosted by the University of Ghana. Next slide, please. So these are the study investigators. Professor Bonsafo is among us here. I'm sure you all, most of you know him. And these are the rest of my colleagues. Next slide. So we have a number of study partners. The Concept Foundation is the sponsor and coordinating a lot of the activities. We're also working with the Bennett Tills. And these are the other trial sites in Africa. Next slide, please. So just to emphasize the aim of the study. So this study seeks to, the aim of the study, the primary aim of the study is to evaluate a regimen of 150 milligram daily dose aspirin compared to 75 milligram oral aspirin in women identified as high risk of preeclampsia based on the restricted MFM algorithm screening. Next slide. The trial primary objectives. 1, to compare the effects of a regimen of daily 150 milligram aspirin to that of when given to women who are known to be at high risk of preeclampsia following the use of the screening algorithm. And number 2, second primary objective is to compare the effects of a regimen of 150 to 75, looking at the occurrence of composite measure of PPH-related treatment in this high-risk population. Next slide. So we have a couple of secondary objectives as well, which looks at PPH treatment occurrence in the various women, the effect of these 2 doses on newborn health outcome, and then importantly, after all this work has been done, we are looking at the cost effectiveness of the different regimen of low dose aspirin. Because should this become a policy recommendations, the next thing is, will it be applicable in our setting or other settings similar to ours? Will the aspirin be affordable? Will the aspirin be of national health insurance in Ghana, for instance? Will midwives at the primary care centers where these women report be allowed to prescribe low-dose aspirin for prevention of preeclampsia? And also, we want to assess the extent to which the Fetal Medicine Foundation screening algorithm can be implemented in our part of the world. Remember that so far it's only using most of the high-income countries. So for the first time, we are testing the use of this algorithm in our part of the world as well. Next slide. I think it's probably the last. So the PEARL study has a number of components. You notice that the clinical trial itself is the last one. Because before we can conduct the clinical trial, there are a number of questions that we need to answer first. First, we are conducting a formative research. First of all, to test the algorithm. Is it able to correctly predict high risk of preeclampsia in our population? And that we are going to do with just a cohort study. Then we are also testing the diagnostic accuracy of the TOMIS app and the intelligent ultrasound. I didn't mention that one earlier. One of the key things in this trial is to be able to correctly determine the gestational age of the pregnant women. So we are certain that they are less than 20 weeks. We know that in primary care settings, ultrasound determination and its accuracy is a challenge. So for this trial, we are deploying the use of intelligent ultrasound. That doesn't require the midwife or the nurse to know even how to do ultrasound at all. All it does is that to give the midwife a cordless probe, ultrasound probe, that it takes 6 strips on the abdomen. Once the woman is pregnant, the AI system in that ultrasound will automatically calculate the gestational age for you. And so far, we were able to train our research nurses within 20 minutes to be able to perform that ultrasound. And that ultrasound takes you only 2 to 3 minutes to perform, and the gestational age will be automatically generated for you. You don't need to know how to determine biparietal diameter. You don't need to know how to measure crown ram length. All you need to do is just sweep on the abdomen times, and the gestational age will be calculated for you. And that makes life very easy. Once we are able to do these ones, then we can determine correctly the gestational age and that. So this is just to show you the sites where this study is going to take place. We are proposing, we've identified 16 facilities all in the Greater Accra region for logistic reason. And these have been put into 4 clusters. So this is the Kolebu cluster. That is the Rich Hospital cluster that includes Lekma, Mamobi, Osu Maternity Home, and then Rich Hospital, of course. Then this other cluster includes Dodoa, Amasaman, Weja, Achimota, and then we have the Tema area cluster as well. That includes Tema General Hospital, Polyclinic, Ashaman, and then Adan East Hospital. So we try to spread out the antenatal attendants at these various facilities and their annual deliveries, and we believe that with these numbers of antenatal attendance and annual deliveries, we should be able to recruit adequately and in time for this trial. Thank you very much.
Thank you very much, Prof. Opong. We are grateful for the presentation. We'll have our next presentation, Jante Owusu. Okay. All right. So Prof needs to catch a flight. So we'll have 2 questions for Prof. Okay, Dr. Fanning.
This pre-trial recommends that we take it at night as compared to during the day, whether it's going to address it as well. And then the second one, I'm asking because we have all the strong stakeholders here. Whilst waiting for the results of this study, I'm sure it's going to inform the national protocol on preeclampsia prevention. Should we hold on with all other calcium and aspirin prophylaxis we are given in the various facilities until we have a national goal, or we can go ahead and do it? I'm asking because we have a protocol in.
I'm sure Ghana is not the only country that is making attempts to solve its problems. Maybe Ghana's preeclampsia prevention protocol is even late in coming. As you see from the various international organizations' recommendations, there are a lot of recommendations out there that people are using already. But the point remains that the outcomes are varied and there is no single consensus across all these. In fact, even when you do meta-analysis of the best evidence generated so far, the studies are so heterogeneous and the direction of the results are so wide and apart. It's the reason why the WHO considered this 2-dose trial as a research priority to put an end to the debate. Question is, should we wait? I won't say we should wait because I don't know the direction of the answer of the results. So Ghana waits and it comes out that, oh, this result comes out and it's the same as the ones that are already known. Would have lost time. So I'll just say that we should continue and work based on the evidence that is available. After this result has come out, if it recommends something that is different and based on the weight of the evidence, something needs to be changed. Then we'll all know what needs to be changed and which direction the change should go. Should the timing of the intake of aspirin change? Yes, the aspirin trial has its own criticism. I'm sure you know that. Because other trials feel that the timing of taking the aspirin doesn't matter as well. So one thing we are conscious of with this trial is to keep some level of pragmatism as much as possible. Already pregnant women have a lot of challenges taking medication. And in fact, they are taking a lot of medication already. And you are coming to add on this one. So if you restrict them to taking it at a particular time and they don't comply, you don't get anything. So we will try to be pragmatic as much as we can, so long as the woman the compliance is good and she's taking the aspirin. So we will not restrict them to taking it only at night.
I think I'm the next one. Congratulations with a very good trial. I think it's a very important question to answer. I wonder, when I look at the FMF algorithm, Black African is one of the risk factors, so is not everyone in Ghana positive then? Screened. So why not include all women in Ghana? Why using a high risk model? Because everyone will be high risk. So you don't need a lot of money to do all the tests of PLGF and so on. So I think that's very pragmatic, but...
That is so true. You notice that even among blacks in the UK, the risk status is as high as about 40%. If you come to sub-Saharan Africa, I don't know the answer yet, but I believe it will be much higher. And in fact, it's one of the questions that the formative trial will help, the formative phase of the study will help us answer. Currently, we have estimated our sample size based on European risk level. But we are quite certain that by the time we complete the formative phase and be able to correctly identify the prevalence of the risk, maybe the 20,000 plus I'm talking about may even be halved. And that will actually be to the interest of the trial. So we won't take as much time as we anticipated. We probably won't spend as much resource as we anticipate.
And my last question, what's your advice on calcium intake? Could it be an idea to advise all women or to prescribe calcium medication? Because otherwise you will have those who have it and not, and then you have to analyze again. So
that is so important. Before, whilst we were writing the protocol, we actually gathered the protocols that are being used for preeclampsia prevention in all the 3 countries. And we realized that most of them are putting women on calcium. Because of that, we have made it uniform that every woman in the trial will have calcium in addition to the aspirin. So that some don't take and others are not taking. Again, risk is as calcium beneficial to us. I was having a discussion with Sof earlier on. Calcium supplementation will still be beneficial. We are not negating any of the known effects or known processes for improving the prevention. This trial seeks to add on to what is already known, so that at the end of the day, what will come out will be something that will improve the outcome overall.
Congratulations. Well done.
Thank you very much.
Thank you very much. We'll take our last question.
So, my question is simple because I don't want.
Where do I press? Okay. So it's on, right? I must say, for us in Africa, we are very much interested in the preventive aspect of preeclampsia because we believe, owing to our peculiarity with limited resources in managing preeclampsia when we have them, we feel our surest bet in decreasing the burden of preeclampsia has to do with prevention. So because of this, we are very much interested in anything preventive when it comes to preeclampsia. So I'm very happy Prof. Opon's presentation preceded mine because we've been schooled extensively on the role of aspirin in preventing preeclampsia. So we decided to check if as clinicians we are making our women benefit from this preventive aspect of preeclampsia. And this was a large study. For the purposes of this presentation, we just teased out the first specific objective for this. So this is just statistics on the burden of preeclampsia at the study center in Confanoche where the study was done. And it was, if you look at the last 5 years, right, preeclampsia has contributed to the most admissions in all the world. To put emphasis on it, look at the cases that come second. Always preeclampsia that doubles or triples it. So that tells you the burden we have with admissions when it comes to preeclampsia. Next, please. With respect to maternal deaths over the 5 years, it's same, with the exception of 2020, where obstetric hemorrhage was the leading cause of maternal mortality. Over the past 5 years, our hypertensive disorders of pregnancy, of which preeclampsia is key, has contributed to the most deaths in the hospital. All right, next slide. Please go on to the next slide. All right, so based on this background, what do we know already? We've heard the lecture on aspirin. And now we know there's an overwhelming evidence that aspirin initiated at least before 20 weeks prevents early onset preeclampsia. And emphasis is on high-risk women, right? We can only identify these high-risk women when we screen them. There is no way you identify them if you are not screening them. So we know that low-dose aspirin given before 20 weeks prevents early onset preeclampsia in our high-risk women. However, during our rounds, what we practically notice is that you have a lot of women admitted with preeclampsia who, at the beginning of pregnancy, were high risk if they had been screened and would have benefited from aspirin but never received aspirin. So we set out to determine the proportion of high-risk women in our hospital that were given aspirin in preventing preeclampsia. Next. All right, so what we did was a cross-sectional study over a period of 4 months. We used a structured questionnaire and a review of obstetric records of the patients. And for emphasis, we used the NIC guidelines in defining who a high-risk woman is for preeclampsia. So please go on to the results so that we make this quick. All right, so this is important to note. When we did it, out of 271 women that we had, we realized that almost 60% of the women at the beginning of pregnancy, if we had screened them with any of the methods, and practically for us, because we don't have access to sonographers to be doing Dopplers, as in our uterine artery Dopplers, we don't have well-equipped labs to be doing the PIGF S-plate ratios. What is available to us practically now is the history-based screening approach. And if we even adopt that, whilst we wait for TOM-APP, whilst we wait for well-equipped labs, whilst we wait for sonographers, we will be able to identify women who will eventually go on to develop preeclampsia. And once we screen and we know that low-dose aspirin prevents and can be commenced on this preventive intervention in an attempt at reducing the burden. So we had almost 60% of our women high risk at the beginning of pregnancy. Then this second one is showing that of these high risk women, we decided to see how many of them actually received aspirin. And it was woefully just a quarter of the women. So we are not screening, we are not picking the high risk women, and we are not giving this cheap interventive aspirin that we don't know reduces preeclampsia. Next slide. All right, so we looked the few that gave. We looked at the factors that is associated with the few women who receive aspirin, and we realized that those who book early, right, and those who booked for antenatal care at higher facilities, mostly the tertiary hospitals, and when at booking, you are seen by a doctor. So being seen by a doctor, we realized that at the tertiary hospital, there were a lot of, as Confaroche, there were a lot of maternal fetal medicine specialists who actively screen for aspirin. So this accounts for these results. Being seen by a doctor at booking, booking at a higher facility, and booking early are some of the features that were associated with. Based on this, based on the results, irrespective of the facility, right? So if we are all doing this, then we can confidently say who will go on to develop preeclampsia. Then we can either refer for prompt face-to-face specialist consultation. Should we be empowering midwives at even primary health centers to be prescribing aspirin? These are things we can.
3 years ago, and then we realized that it had extremely low uptake of SP. So we wanted to find out why. We did a cross-sectional study. We recruited 416 participants who were attending only, and if it is only in ANC per the current policy that a pregnant woman can receive IPTP or SP. We included pregnant women that were more than or from 36 weeks and above, and then we excluded pregnant women that were allergic to sulfur, specifically were either partial defect to this is another researcher who had done a similar work earlier on. So for quality control purposes, after we modified the questionnaire, we trained our research assistants,
We did a pre-test because it was done in a different place. We found some issues we had to resolve. We did a rephrasing. And then after we collected the data, we ensured double entry so that we minimize the errors. Our dependent variable was IPT participants. The next slide, please. All right, so these are our demographics. I don't want to go in. Please, let's go to the next slide. All right, so we decided to compare other studies with our findings, the findings from other studies and ours. Specifically studies here in Ghana to give all of us a fair idea that what we found is not just in that particular locality, but it's actually spreading across. So in our study, we realized that with knowledge of, and more than 90% didn't have full knowledge about it, and didn't even know why they were taking the medication. Very few, less than 10, observing them to take it. So I was now wondering, were there instances that providers went to their homes to give them those medications? Were from 20 weeks and above. And in Ashanti region, it looks like it was a bit better. We had 16 to 19 weeks of them, our pregnant women taking it within 16 to 19 weeks. So we want to find out what Ashanti region is doing. Maybe other regions can learn and then it could improve it. Though it is not the best. They really have significant relation with it. And we realized that for the optimal dose, and we did a further studies after this, which we are still working on, yet to be published. And that one was a qualitative study. I could share. Some of them, most of them were like, because they were able to time in which a pregnant woman or not, definitely go in for it. Please, the next slide. I think I've basically spoken about this already. The next slide. Since we are now getting to know that some of them are taking it in the house, maybe we wouldn't have captured them. And that were what was influencing their decision making. And then we could also get those that were not attending ANC to also get their views on this. Please, the next slide. All right, so in our conclusion, we think that the knowledge on SP has a very high significance in the use, the optimal utilization of SP. And so since we have people from important stakeholders here, we want you to send this across so that since the drugs are available, they should be given to our women. And then majority of our respondents were suboptimal users because of education and then the age. So if we're able to get them coming to the ANC early, or we're able to capture them one way or the other early, then we'll be able to increase the optimal dose levels. Please, the next slide. And then we also, one thing we also concluded was that if we had involved the men, because they are the decision makers in the parts that we took our studies, probably they would be able to.
Thank you very much. That was a nice presentation. So my question is with regards to the recommendation of community health nurses giving the SP to the pregnant women. How feasible is that? Because we know that we have to check their G6PD before you can administer the drug.
Thank you for the question. So we'll take the last one.
Thank you very much. I'm happy to see that somebody is sort of acknowledging the type of research I do. Yeah, we have published some study that have identified that even women who have taken one dose of IPTP have parasites, malaria parasites in their placentas, which we have studied. And this was higher generally in the women, but they sort of segregated them into hypertensive groups and those who were not hypertensive. So maybe going forward, you can look into that. Thank you.
No. Hey, okay, two people want to ask, but they say no. No means that is it. So please react and then we'll move on to the last.
Okay, so I think I'll start with the first one. The administration of IPTP, it's not like when they just chance on them that they are pregnant, then they are giving them the medication. We recommended this because of the concept of CHIPS. Now, CHIPS facilities are almost everywhere the first time. They would refer them to the facility, and the first booking, all these labs are done, including the GCSPD. So those that are supposed to take it, they take it. Another thing that our current study that we didn't talk about here today also let us know was that some people would also start and then would default. By then, all the labs have been done already. So when we use the community health nurses, we'll also be able to capture them. And those people also fall under the suboptimal category. All right. And then I've taken notice of your submission and we'll work on it. Thank you.
Yeah, so thank you. I think a window was created because she said only two questions, but she didn't add the number of people to add comments. Mine is a comment, and I want to give Adam and Roberta, a plausible reason why malaria may be associated with preeclampsia, so that in your subsequent presentations, probably you may give, you may state that. Currently, we are going to do something, CAF and KCCR and Munich University. We're going to do something about whether there is an association between schistosomiasis and preeclampsia. Because we now know that during pregnancy, there is maternal immune modulation, which will allow the placenta, the thromboblastic tissue to invade spiral arteries. So if this does not occur, then there will be defective deplacentation, and that is what we all know will be the consequences as preeclampsia. So we think that chronic inflammatory states may limit this maternal immune modulation. And if we are thinking about schisto, then it's possible malaria can also cause that. And I think there may be some association. Thank you.
Thank you. Comment well taken.
Thank you very much for your cooperation. So we are going to have a plenary session now, and it's going to be led by or moderated by Dr. Hannah Amwako Brown. The panelists that she'll be engaging will be Dr. Emmanuel Shofenyo. Please let's welcome Dr. Shofenyo. We'll be having Prof. Kwame Edubonsafo. Professor Kwame Edubonsafo. Okay. All right. So we are having. Okay. All right. So we'll have Dr. Yao Jante to be part of our panelists. And then finally, Dr. Betsy Ananifening to be part of our panelists. Professor Kitty.
Always lean towards maternal
and obstetrician
education. We look at what they have and see can do advocacy so that they can be better equipped, and also whether they can get more training, so we get more value addition to the staff who are there, so they can deliver better. So when they are better resourced, human resource is better trained, they have more knowledge, and they have more even with the basic facilities.
Wonderful. We've heard a lot generally about the healthcare system, but I think more from the public side. So in your view, I know that because of your connection to SOGOG and your practice, I would like you to share with us the disparities that you see even in the private healthcare setting. Because we do have quite a number of private health facilities. At least in Accra, I know we have a lot, and I'm sure Kumasi is not too different, or the big cities are not too different. So what kind of disparities do you see, or have your colleagues mentioned to you that relate?
But they look at all this, and then some of them are able to follow up when they refer some of these patients, but the others leave them hanging. Once they give you the letter, that's the end, referral letter, then they leave you. And so I think that there should be a way that, if you look at Ghana, for instance, the private sector please actually delay patient referral. So when the patient comes, they try to initially manage. Sometimes they actually also face real-time challenges when they need to refer patients to the facilities. Let's face it, sometimes a private person will call us, and the mere fact that the patient had started from the private side, truly, some of our colleagues make life sometimes extremely difficult for the private, probably the best for the patient, but they look at all this, and then some of them are able to follow up with any meaningful support in this facility. So I want us to all understand that we need to embrace the work of and we need to appreciate that also, because they also help with the management. And sometimes somebody will ask, why is this patient not managed there? Why did you have to come here? Because you went there. We need to embrace what they do. We need to appreciate it. We need to also add those. So for instance, if you look at the the National Health Insurance Scheme, to embrace it and try to also make sure.
The summary of what I get is that there are peculiarities when it comes to the private sector, yes, which are quite different from what you see in the public health sector related to how we manage our cases of hypertensive disorders of pregnancy.
Yes, sometimes they may not have all the resources, but they respect the patient. They involve the patient sometimes in the management, and that's what patients actually want to. Women want to be involved in their care, but as you know, in Ghana, somebody say, I'm the doctor, you can't say anything. And so they are able to do that quite in course sometimes better than the public sector, and the delays are quite minimal compared to what women face when they get to. So these are things that some women actually want to go to the private sector because they know they will be respected, they will be involved in their management. Let's just give an example. If you remember, the TB is the traditional birth attendance. You ask yourself, why would a woman want to go and deliver there? Because when they go there, they talk to them nicely in a language they understand. They speak to them in a dialect they appreciate. And so they feel like this person is part of me. And so they give their all to the person to treat them. When they come here, they see quite a big distance between them and the health professionals.
We have a lot of medical jargon we bombard them with, so then they get tired
so
of us.
They don't even know what to say. Yeah. And because of that, don't let us think that normally when they say, oh, doctor, you are the doctor, so take the decision for me. No. They do that because that is what they think we expect them to do. If you really come down, you sit down with them and you ask them.
I think I'll move on to complain about. And as we think about our challenges, I think it's useful to country and being in and out of this country. What do you think is working for us in this country when it comes to how we take care of patients who have hypertensive disorders of pregnancies? What should we be proud of?
Yes, very difficult question, I think. And the answer will be that you know yourself the best where the problems are. That's one. The other thing is I like to measure regions where there are probably then also more maternal deaths. So I would like to see how many maternal deaths are in which area because of hypertensive diseases, and then the why question. So, and I think we discussed yesterday in depth audit, and we heard it today also. I think that will time to start. Go and make a 2x2 table. Which are the quick wins and which are the wins who are taking more time, but you can achieve and will get a lot of improvement. So to change the roads, it's difficult, it will take years. But what you could do is thinking about impact at all. So really think, where can I improve?
So I'll come to you, Dr. Finney. What do you think is working well in our country when it comes to how we manage hypertensive disorders of pregnancy, and what is not working well? What are our challenges?
So what strong tendons and even preeclampsia, as we are talking about. So that is where I see our biggest strength, the community impact of the community health personnel.
And if I may come to you, Dr. Stroff, in your opinion, how do we leverage on this to improve health outcomes for women who have hypertensive disorders of pregnancy? If we have such close collaboration and very good community engagement, how do we leverage on it? What is missing in what we are doing now?
Thank you very much. Really, what is really missing now is how do we, once the woman, let's say, comes to the antenatal and booked and goes home, and she's been given 2 to 3 weeks to report back, what is the follow-up system in place for such a woman? That is one thing that currently we don't have a good follow-up system, and that is a gap that the community health nurses and other community interventions are meant to fill. And we seem to be doing well, but we are not yet there, because they come, when they go home and have complications, the system in place, for all we need, one thing is that they don't even have the telephone number of the community health nurse. Their mind is all fixed to the big hospital where they went to book. So if we can have a system where the community health nurse, knowing her job, have some kind of relation with the people in that community, so that even in that community, if they have any immediate need health-wise, they know the one to speak to, who is close by them, so that within 5-10 minutes, you have to report to your hospital immediately. Like that woman who yesterday was presented, passed away. If the issue, maybe when she got home, she had some problems. But if there was somebody that they could have just called to just come, check, and then tell them that, look, report back to the hospital, she wouldn't have lost her life. So these are the gaps that I see in our community health systems. We need to strengthen the community issues so much so that the community members will know the go-to person.
That you have a kind of outreach program that you...
Clinical clinic with them. We went to see their theaters, what they had, the key things like obstetric hemorrhage. And we went to see their theaters solution. Go and find out what are their problems. So it's going to be an interaction. So as we go to find out their problems, the solutions are in what they will tell us. Apart from the information that we are also taking out. We don't want to create a situation where they feel that they are down and you are up there. No. Rather, we are working as a team. We've come. What are the issues? What are your problems? And then this is what we also have. Let's work together to improve. Where we have to improvise, we improvise. That's it. I wanted to add to just some of the things about the strengths that we are having in the country.
Please go ahead.
Yes. You see, we have the national ambulance in maternal health and the pediatricians interaction. So as we go to find out their problems, the solutions are in what they will tell us, apart from the information that we are also taking out. Yes, so that we work together as a team with them. It's not like we don't want to create a situation where they feel that they are down and you are up there. No. Rather, we are working as a team. We've come. What are the issues?
Usually, I don't hear managers of hospitals praising the National Health Insurance Scheme, but on this occasion, it has happened. So, it means that at least you can enter the hospital, which is a good thing. Thank you very much for sharing that. Because of time, we'll quickly move on to strategies for preventing and managing preeclampsia. I would like to go to each of my panelists, and I would like them to mention one important emerging strategy that they find useful and think Ghana can adapt, and how we think we can adapt it. So I will start from Dr. Stroff. Am I a difficult examiner? As the Lord's here, which is a good thing. Thank you very much for sharing that. Because of time, we'll quickly move on to a few other topics. So again, one of the discussion points we have is the emergent strategies for preventing and
really admire. And so when they are sick or they have any problem, let's not forget this. They go first, most of them will go first to their spiritual leader. They go first to their pastor. In fact, we have witnessed patients who come with eclampsia or even imminent eclampsia, if you want to put it that way, and you want to give them magnesium sulfate or you want to treat them. And listen, so I think we should refocus a little, look at how we can integrate these people. The churches, we shouldn't worry if we need to even put an automatic machine there, educate pastors, educate traditionalists, educate herbalists, and they all get to know. Education will help us. So I will leave the big things for my other friends, but these are things that I think we should not forget. If we forget, the treatment, sometimes, as we all know, the treatment, we don't even know whether I should give you this or that. If you give that, sometimes it doesn't even work. But if we can look at these simple things that they are low-hanging fruit that we can look, because we are really religious and respect culture so much, and we can start from there and meet the other people when they are coming with those high-level information. Thank you very much.
Thank you. So if I can summarize, your focus is more on contraception, on respectful maternity care, and then education of non-medical significant leaders and enrollment of them into, programs related to hypertensive disorders of pregnancy. Well noted. Thank you very much. Kitty.
Yeah, I would say prevent obesity, but it's a difficult one. But it has to start with the children. Don't feed them too much. Because I have to say, you cook lovely, but it has a side effect. I noticed already in 1 week. So thank you for that. So that would be my advice first. But that's a difficult one because it's in the culture and going on. But obesity is really one of the major risk factors for preeclampsia hypertensive disease. The other thing, what I'm impressed by, is the power of the women. And I would say use that and much more. As what you say, respectful maternity care, yes, completely agree. But I would want to know more about the disease. Ghana is so proactive in this. We would say, doctor, you can't send me away because my blood pressure is too high. Don't send me away. Yeah. The other thing is, you have a very strong group of midwives. I know there are some male midwives, but most of them are women, and they experience themselves the problems of preeclampsia hypertensive disease. So get them, and it's the same in the community, what I heard. I mean, that are the places to give the knowledge.
For this conference, one of the things I was really looking out for was the issue of screening and prevention. And I'm very happy that it has come up several times in our presentations. We gather the women from before they are even referred to us at the bigger hospitals. And from the presentation, particularly Dr. Jante's presentation, so cheap. I understand that sometimes calcium carbonate alone is difficult to get. And I know that sometimes they count it in tablets, 2 cedis per tablet. That is a 500-gram tablet. So it may be expensive. This is where NHIS has to come in. This is where Ghana Health Service needs to be our mouthpiece and advocate for it. A few days ago, I had to engage the NHIS boss in Central Region because they almost rejected it. But I realized that she was very receptive. When I tried to explain it, she understood it perfectly, and she gave us solutions as to how to get our claims reimbursed. So I think that the screening, we cannot overemphasize it, and it has to be down there from the primary care level before even the tertiary. And that's where I'm very sure we'll be able to maximize our efforts against preeclampsia.
Thank you very much, Dr. Labi.
Thank you. When you're ambushed, you really become very productive. Yes. All that I stole the age screening because I was going to talk about it. Yes, I don't know what to say now. Yes, that's on the light note. But what I want to say is that we have this. I've mentioned before. We have this maternal referral platform. Now, a lot of people use mobile phones. What can we do to ensure that maybe in various communities, or I know in Cape Coast you do something. There's something that you do so that people are zoning.
The
so
zone.
you have
Yeah.
SOD. Use your machines that were sent to the CHIPS compounds. And it was a 10-day training program of what they had done. And we were communicating normally with this baby. And so
if you see this, this is where you have to go. Education is key. And then my last point is that advocacy. They've mentioned fantastic ideas here. I don't think we are going to sleep and wait for another year for us to gather again and start talking about preeclampsia. SDG 2030, halfway. What is expected of us? We're supposed to reduce our maternal mortality ratio to below 70. Is that right? Where are we now? 263. Are we able? I think that's a question for us. I am hoping maybe next year when we come here, we'll be told that probably we've gone below 263 to maybe 200. It requires collaboration from all of us. We need compassion for our patients. And then collectively, I believe, have been able to do it. Other third world countries have been able to do it, to reduce their maternal mortality ratios to less than 70, as we have in other developed countries. Which country? I think, is it Sri Lanka? One of the third world countries, Sri Lanka, I think, has their MMR less than 70. And I think we can do it. There's a lot of fantastic ideas that our panelists has come out with. So let's go back. Let's educate our presenters. And for those of us who will be traveling outside Kumasi, we wish you a safe journey to your destination. And then to our organizers, we say, Ayiko, for the great job done. And God bless you. Amen.
There is no better way to give a closing remark than what our able chairperson has done. Let's give it up for him again. So when I say APEC, when I say APEC, you say saving precious lives through advocacy, research, and support. APEC. And we know with enthusiastic researchers, clinicians, Koiwa Labi, Ms. Koiwa Labi, the executive director of APEC Ghana, to do some acknowledgements. Sadwe, oye.
Good evening, everyone. My apologies for the late closing, but we are wrapping up. We just want to thank everyone here, and in doing so, we want to just give some citations to our host, our partners, and a few. With permission, I'll call the chair of the planning committee, Professor Terry Odoy, to join me here. And you can take on behalf of and children. We are investing in the future of our society. So, please. Gratitude. The quote we have there is maternal and children. Thank you. KNUST SMS. And we actually, Prof, don't go, we have society. Thank you, Professor Mchi Kusi. We have one for our keynote. He's not here. But we wanted to give one specially to Dr. Atta Owusu-Bempah of CATH. He was very, he played a special role in the planning. He's not here, and so we will give his on behalf of us, and it's in the same manner. And then for the Regional Health Directorate, they are not here. Dr. Emmanuel and the pregnant woman who carries within her the support of empires and the gem of future generations. So, Regional Directorate, okay. Professor Doi is going to give the vote of thanks. Professor Doi, before you do that, I would want you to acknowledge and have all the APEC volunteers come here, and then together you can thank them.
Thou sayest so. So please, all the APEC volunteers, please come here. Come here, come here, come here, come here, come here. One boom, one boom, one boom, one boom, one boom. So do it, 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 so do it. Yes, can you give us a shot before? This is a special one. For all of us, the volunteers, including Kuewa, we are all volunteers.
Emmanuel, please show yourself.
Where is Emmanuel? So I've been asked to give the vote of thanks. I thought the able chair did justice to that.
I can see acknowledgement and vote of thanks. In English, they are like synonyms. In obstetrics, I think they are identical twins. Because acknowledgement is, I don't know. So I think what you are doing, you are giving birth to twins.
Well, okay, so I can repeat, even triplets can even come, isn't it?
Yes, please, you're allowed.
Okay, all right. But let me ask a question. We say that our target is to reduce. Who wants her sister, her auntie, her relative, her friend to contribute to that 70%? No, to contribute to that 70%. Yes, the 70%, that is our. Who wants his relative? I don't get it. I think if we all adopt the attitude of zero tolerance, then as if Udu 80, as if when you reach 80, you've done so much. I disagree with any figure. That is more than zero. That is my policy. We should all aim at maternal mortality of 0, and it is achievable. Okay, so we've had 2 wonderful days. Some of us couldn't be here all the time because we were doing other things for the country and for the world. But thank God, you've all done very well to be present at this point. And we thank the good Lord, so we thank God for that. Secondly, we thank our able chairman. I enjoyed his chairmanship so much. And I think you got the right person because you are dealing with high-risk pregnancy. And we got somebody who is into high-risk pregnancy anesthesia. And he's delivered very well. Mr. Chair, thank you so much. We are happy to have you. The citation and the thanks and the special portmanteau and sent to him. But then, all of us who are here, we deserve our special thanks. Because without you, this would not have been possible. Some of you travel far, and I mean, people flying all the way from abroad and coming here. We appreciate it so much. Some of you traveling from other parts of the country, we appreciate it so much. So we thank you so much. We believe that the numbers will keep increasing. Say amen to that. And finally, we thank again all of ourselves and congratulate ourselves for making this program a successful one. God bless you.
Thank you, Professor Terry. I think I'll hand over to our moderators. But before I do that, I want to acknowledge our local representatives here. That's our regional coordinator, Mavis, and especially the one who led the coordination, everything here, a member of the Executive Council, Professor Linda Ahinkra Funjo. Please, if you can rise up. Without her coordination, we wouldn't have been here. So, on this note, I think we wish everybody well. Have a safe journey back. We don't know what next year holds, but if anything, we'll all know and communication will come through. Moderator, thank you. She's been a wonderful moderator from last year and this year, and we love your vibe. And your co-moderator, Dr. Hectoria.
Thank you very much. Please, we would want to take our closing prayer, and then we'll be out of here. We know God will grant us journey mercies. Who is led by the Spirit of God? Please, we would want to take our closing prayer, and then we'll be out of here, led by the Spirit of God to lead us in the closing prayer. Please raise up your hand, then I will invite you to pray. Please, one more.
Thank you. Please, let's pray. Heavenly Father, we thank you today for giving us another opportunity. Thank you for bringing us together near and far. We thank you for what we have learned here. When you give them traveling mercy back to their home, we thank you in the name of Jesus. Amen.